digital, dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JSC. Dengan layanan JSC Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JSC Cloud melalui kontak center JSC di 0804 122 1000, email jsccloud@jsc.co.id atau WhatsApp JSC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget, apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JSC. JSC Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda. JSC Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan jumlah pasien dalam pengawasan lebih dari 15.000 dan orang dalam pengawasan lebih dari 170.000. Kota-kota besar di Indonesia sedang memberlakukan pembatasan sosial berskala besar atau PSBB. JSC Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JSC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JSC. Dengan layanan JSC Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JSC Cloud melalui kontak center JSC di 0804 122 1000, email jsccloud@jsc.co.id atau WhatsApp JSC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget. Apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JSC. JSC at Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda.
Tes. Masuk ya?
Tes. Mas Ipin bisa dengar suara saya?
Masuk, Dokter Vira, masuk.
JSC at Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan jumlah pasien dalam pengawasan lebih dari 15.000 dan orang dalam pengawasan lebih dari 170.000. Kota-kota besar di Indonesia sedang memberlakukan pembatasan sosial berskala besar atau PSBB. JSC at Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JSC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JSC. Dengan layanan JSC at Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JSC at Cloud melalui kontak center JSC di 0804 122 1000, email jsccloud@jsc.co.id atau WhatsApp JSC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget. Apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JSC. JSC at Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda.
Halo Dokter Aik.
JSC at Cloud. Kasus COVID-19 di Indonesia mulai tercatat pada tanggal 2 Maret 2020. Saat video ini dibuat, sudah lebih dari 7.000 kasus positif COVID-19 dengan jumlah pasien dalam pengawasan lebih dari 15.000 dan orang dalam pengawasan lebih dari 170.000. Kota-kota besar di Indonesia sedang memberlakukan pembatasan sosial berskala besar atau PSBB. JSC at Cloud, teleoftalmologi pertama di Indonesia. Apa itu teleoftalmologi? Teleoftalmologi adalah layanan terbaru dari JSC yang memberikan layanan kesehatan mata melalui peralatan medis digital dan teknologi komunikasi, konsultasi video online kesehatan mata dengan dokter spesialis mata JSC. Dengan layanan JSC at Cloud, Anda akan mendapatkan pelayanan secara online berupa konsultasi video dengan dokter mata terpercaya, fasilitas antar obat hingga rumah dengan kurir online. Daftar sekarang juga JSC at Cloud melalui kontak center JSC di 0804 122 1000, email jsccloud@jsc.co.id atau WhatsApp JSC di 0878 2922 1000. Di rumah aja membuat mata lelah karena sering bekerja dengan gadget. Apalagi bagi para penderita glaukoma, retinopati, dan kondisi gangguan mata lainnya, di mana penglihatan harus selalu dijaga secara rutin. Hindari kebutaan dan konsultasikan mata Anda dengan dokter spesialis mata JSC. JSC at Cloud merupakan solusi untuk permasalahan kesehatan mata Anda di tengah pandemi COVID-19. Aman dan nyaman untuk Anda.
Good morning, Indonesia. Good evening, Canada. I would like to welcome all speakers, presentants, and also to the all participants of JC Saturday webinar series. And our series today is with glaucoma service. We will divide the sessions into two. Our first session will be moderated by Dr. Vira. So for the first session, we will have Dr. Aik Ahmed. Hi, Dr. Aik. How are you? Hope you are well today.
Thank you.
And Dr. Aik will have two topics today, and we also have Dr. Vivin from Dr. Emma and also Dr. Zeras from JECI Hospital in Jakarta. And the second session will be moderated by Professor Widya Artini, and the speakers are Professor Tin Ong and also Dr. Vivin and Dr. Dian Arundini. So I will give Dr. Vira, the floor is yours to moderate for our first session. Dr. Vira is our ophthalmologist from JCI Hospital in glaucoma service. She finished her glaucoma fellowship in Lions Eye Institute, Perth, Australia. Dr. Vira, the floor is yours.
Thank you, Dr. Rini. Can you hear me right, Dr. Rini?
Yeah, sure.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. My name is Arini Safira Nurul Akbar. I will be the moderator for this session. First and foremost, on behalf of the committee and JECI hospitals and clinics, I'd like to express our gratitude and warmest welcome to our speakers, especially to Dr. Aik Ahmed for his willingness to stay up so late to share his outstanding expertise and knowledge in glaucoma and anterior segment surgery. I reckon that it's already 9 p.m. there, right, doctor? But thank you very much, doctor. We really appreciate it. As previously mentioned by the host, we will hold the Q&A session after our three speakers are done with their presentation. If you have any comments or questions for our speakers throughout their talk, you may post them in the Q&A box, and we will try to address as many questions as possible during the Q&A session. It is a great pleasure for me to host this exciting session as we have three great speakers. We will start this session with our first speaker, Dr. Iqbal Karim Ahmed, or famously known as Dr. Aik Ahmed. I'm sure most, if not all of you are familiar with Dr. Aik's outstanding works. Dr. Aik finished his glaucoma and anterior segment surgery fellowship in the John Moran Eye Center. He then became the assistant professor in University of Toronto and clinical professor in University of Utah. He is currently the division head of ophthalmology at Trillium Health Partners. He is world-renowned for his skills and groundbreaking work in diagnosis and surgical treatment of highly complex eye diseases and surgeries. He has developed many novel therapeutics approaches and designed innovative microsurgical instruments, devices, implants, and techniques. Some of his many accolades are his achievement in many prestigious awards, such as the Binghorst Award, the Innovator Award, and the American Academy of Ophthalmology Senior Achievement Awards. He is rightly acknowledged as the father of mixed microinvasive glaucoma surgery. I believe you coined the term yourself, doctor, and quoting an article in the Ophthalmologist, the rock star of ophthalmology. Today, he will talk about cataract surgery in complicated glaucoma cases and surgery in advanced glaucoma. Without further ado, I'd like to invite Dr. Aik to share his presentation for today. Dr. Aik, you have 40 minutes to deliver your talks. The floor is yours.
Arina, assalamu alaikum. Thank you very much for the invitation. I would be up 3 a.m. to be with you in Indonesia, and it's been a dream for me to be to visit one day, inshallah. And I hope I will be able to do this. And I hope you guys are being safe. And I also want to wish everybody a happy Eid Mubarak. Today we celebrated Eid in Canada, a little bit social distancing, of course, but it was still a very important day for us, of course, commemorating the commitment and the sacrifice as the story, of course, of Prophet Ibrahim, and of course the holy day of Arafat and the day of Hajj as well. All of these are important days for us. So it's an important day, and this is a way to end my day after having dinner with my family. And I told them I will be talking to many of my Indonesian friends. So thank you very much. I do have a couple of presentations that I'm pleased to share with you, and I hope that they may be of interest. I know that you have many great specialists in your country and around, and I hope I'll be able to share maybe some interesting pearls, and happy to take some questions. I know that you may be a little bit tired of hearing me speaking for 40 minutes. I guess it's a long time. So if you want to interrupt me, there's no problem. So my first topic is cataract surgery in complex glaucoma cases. This is an area that I really enjoy managing these cases that have complexities and challenges, and these are my disclosures here as well. So let me first talk about patients who have a previous filtering surgery and they need cataract surgery. This is something that we do see. We know, of course, trabeculectomies and any bleb surgery can increase the risk of cataract progression, and we need to be mindful, of course, of cataract surgery. My general rule is this: when I have a patient with a bleb and they're having cataract surgery, I decide whether the bleb is working well. If it's working well, I don't do much other than I do, of course, do safe phaco, and I do inject typically with antifibrotics like 5-FU, and I use lots of steroids. But the patient, for example, whose bleb maybe is borderline or not working very well, I think that's an opportunity for us to do something. And I'm just going to show a video here of this case. You can see the superior bleb I'm outlining here is pretty flat, fairly injected, and vascular. You can see I'm going to start with this case. I'm just injecting first here some mitomycin. I typically use 0.5 milligrams per cc when I do a reoperation like this, and I let it stay there as I start the case. I will then start the phacoemulsification, which is pretty straightforward, pretty simple. I will in the capsular bag, and I leave the viscoelastic into the eye. Now, I also like to do gonioscopy. You look in this case, you can see the iris has been caught in the ostium, something we have to always be mindful for trabeculectomy, that this can be a cause of failure. This is not one of my patients. Someone else did the surgery, but I was referred this patient. The patient's pressures were very high and I needed cataract surgery, and so I like to do a revision like this. What I'm going to first do here is I'm going to do a little bit of goniosnecholysis. I'm using a gonio mirror. I think every glaucoma surgeon ideally should have access to a gonio mirror to look into the angle during surgery to identify angle closure, or in this case, synechia. And you can see I pull the iris away from the angle, and we now have the trabecular meshwork visible, although the ostium is not so clear. Now I will proceed with doing a needling procedure. I typically use a 27 gauge needle, as you see here, entering posteriorly and then coming down toward the scleral flap. I typically use my needle to find the edge of the scleral flap. I cut across, and of course this is a little bit by tactile feed. And then I enter the anterior chamber. As you can see, the needle now is entering the anterior chamber. And this, of course, is our classic needling approach. You can actually see on gonioscopy, I'm showing my needle, which is entering in the vicinity of the ostium. And then we'll go back and forth, cutting under the flap, into the AC again, to make sure we have a communication. And then we like to make sure we lift the flap up. It's hard to see because the bleb is fibrotic, but you can feel the edge of the flap. Sometimes it's a bit of a blind approach, and we then can raise the flap. And you see at the very end of the case, I will inject BSS in the anterior chamber, and the bleb, you will see, will rise up quite nicely. And we have now reestablished the patient's flow. So I'm a big fan of needling, whether I do it with cataract surgery or whether I do it in the office. If I do it in the office, I do it with the slit lamp. But this is doing cataract surgery in the presence of a bleb that we want to try to maintain. What about dealing with patients who have weak zonules? In glaucoma, there are many associations with weak zonules, including sursfoliation, trauma, angle closure, spherophakia, even after filtering surgery as well. We like to grade these patients whether they have mild disease, like in the left, where a capsular tension ring may be enough, or we may have to use something more, like on the patient on the right, where we see the zonules are quite deficient. We have many options available to us that we have available: the capsular tension ring, the capsular tension segment, and variety of different approaches that can be used for mild to moderate zonular disease. These are all very helpful. They support the capsular bag, for example, using an iris hook with the capsular tension segment to support the capsular bag. These are situations that we see as glaucoma specialists. These patients present with angle closure. They are very young patients, often with microspherophakia, and the chamber can be shallowed because of the lens moving forward. with a very spherophakic microscopic lens. Like this case, for example, where this patient had angle closure, we were able to put the lens back behind the pupil, but this patient, of course, needs to have surgery. And the problem in this case, of course, like most angle closure, the problem is of course, specifically the lens. And these are very small capsular bags. You can see we're using iris hooks to expand the pupil, which is a nice way to manage the pupil when these pupils are small, especially with dealing with these complex eyes. And then you see the bag is small and mobile, and we basically will have to make a somewhat smaller capsular rhexis to ensure we have a continuous rhexis and ensure we have enough anterior capsule support. But the nice thing is that the capsule is fairly elastic and it can stretch. You'll see what we're doing next is viscodissection to separate the capsule from the lens. I really like to keep the capsular bag. I do not like to try to remove the capsular bag and get vitreous and everything else. I like the smoothness and the comfort and the less invasiveness by doing it this way. We now take one of the iris hooks and move it to the capsular tension segment to hold the bag in place. And you can see how now we have the bag supported in one meridian. We'll do the same thing on the other side with another segment, because this patient has really a lot of zonular deficiency. So this patient requires enough capsular support placed 180 degrees apart. And those are what the capsular tension segment does. These are the soft lenses of a young patient with microspherophakia. Remove the lens material. We can then disengage the iris hooks. And look how small that bag is, right? Now we will make a scleral groove. Usually it's about 2.5 millimeters from the limbus, or about 1.5 from the end of the blue zone, which basically correlates to the anterior trabeculum. We want to go back about 1.5 millimeters to 2 from there. We will then be ready to pass our sutures. Now, I do like to use Gore-Tex sutures. Gore-Tex, I know, is not so readily available perhaps around the world, but it really is a fantastic, durable suture that lasts, in my experience, a patient's lifetime. If we don't have this suture, one can use Prolene suture, but Prolene, like 9.0 and 10.0, has been shown to break over time. And so that is less desirable. Here we have the sutures placed around the segment. We tie it in place. Same thing on the other side. And then we have now support the bag nicely in both areas. We can also place a capsular tension ring, which will expand the entire capsular bag as well and provide good round centration. There it is there. And we will then finally place an IOL into the capsular bag, as you see here. And we have lots of things in the capsular bag, but really it can hold this very nicely, and we can finalize the sutures and bury the sutures in the sclera. And we really have what should be otherwise a regular, normal phacoemulsification with CTR, CTS, and IOL in the bag. So that's what we managed. This patient here who has, earlier I showed you, was microspherophakia. And at the end of the case, we see the IOL nicely in the capsular bag and stabilized. What about trauma? Well, trauma, of course, also is a problem. This is a patient who had very high pressures after traumatic injury. Of course, patients get angle recession, traumatic angle damage. And in these cases here, I typically manage with external filtration, either trabeculectomy or tube shunts. And this patient also has iris damage. These are multiple issues: vitreous prolapse, the lens is subluxed. There's a lot of things to manage. Now, this is why I went into glaucoma surgery, because glaucoma surgery often has other comorbid problems like this that require us to use anterior segment and posterior segment approaches in managing the cataract or the dislocated lens. In this case, you can see we will do limited vitrectomy to the pars plana. We will levitate the lens anteriorly, bringing the whole capsular bag forward with a pair of microforceps. I know this is a bit advanced, but I wanted to just show the different complex cases that glaucoma surgeons have to face. This, of course, patient could have had a lensectomy, could have had intracap as well, yes, but I want to maintain the small incision nature, and I want to maintain the capsular bag here in order for us to take advantage of the benefit of using the capsular bag. I'll just fast forward here. Basically, what you'll see is I was able to do a nice capsulotomy, capsular rhexis. The capsular tension segment will go into the capsular bag as we place it like I showed the previous case. And we have a CTR in, we do the phacoemulsification. We pass our sutures like I showed earlier. and we now have nice bag support on both sides, as you saw, very similar to the first case I showed you earlier. But we also have to deal with the iris, and I think it's also helpful to manage the iris because the pupil is very dilated and atonic. Here we're using a pupil cerclage. This is where I use 10-0 polypropylene suture on a CIF4 needle. This is from Ethicon. We're basically using a rolling suture around the pupil margin. This patient's pupil is dilated atonic. If we don't fix this, we have a problem with regards to photophobia and light sensitivity and higher order aberration. We will do a 360-degree pass along the entire circumference of the pupil, tie the suture outside the eye, and different ways to tie. Here I'm using a modified mechanical or what my fellows have called a McAhmed, where we tie the suture and we push it into the eye with a microforcep, and the microforcep is handy to do. So these are handy instrumentation when we have these challenging situations. And then finally, I like to use, in this case, an Ahmed valve, and I do feel that the tube shunts are more durable than what we do with trabs or micro shunts. You can see in this case I'm making a horizontal mattress suture, passing the suture along the sclera for 5 millimeters, and then going back through the eyelids. This is a simple way to do it, so we don't have to do 2 separate sutures. It's one loop, and we will then have the knot buried underneath the implant. I'm using, in this case, 6-0 Proline, which I like to use for my tube shunts. And you can see by this mattress suture, it's nice because it really makes one single pass, easy to do at the right about 9 millimeters back from the limbus. Now I'm using a scleral tunnel here, 22 gauge needle here, back in this case about 3 millimeters from the limbus, and once we reach the posterior limbus, we will enter the anterior chamber. This is a technique we can use that we don't even need to scleral graft. I'm pretty comfortable with this approach in most cases, where we simply have a nice scleral tunnel. As long as it's about 3.5 millimeters from the limbus, this tube should stay nicely buried in the sclera, and the risk of exposure is very low. We don't always use scleral grafts, as I mentioned. And finally, we can close the conjunctiva with sutures or with tissue glue. And this is a very complicated, long case, but you can see we're able to manage this patient's problem in multiple ways with a dislocated lens, vitreous prolapse, zonular problem, atonic pupil, and of course glaucoma, all together done in one shot. So that's a big case, but you can see all small incisions and less invasive. And the result here, after some time, shows a reasonable cosmetic result in the right eye here, and the patient's tube you can see as well. You can't see it's underneath the patient's lid there. What about cataract surgery and angle closure? These are difficult situations. We have very shallow anterior chambers like this, with very small eyes like nanophthalmus. This is a plus 15 diopter patient who also had pressures ranging from 30 to 50. And you can see in the right eye, this patient has a very shallow chamber. You'll see why shortly. Why this patient has a very shallow chamber. The left eye actually was reasonably formed and the angles were open, but the right eye very shallow. And you can see when we do a B scan, we see a significantly enlarged retinal choroidal scleral thickness. This patient actually presented with malignant glaucoma. That was our diagnosis. You can see the very thick sclera, very thick choroid here. And we need to basically manage this patient here. This is important to understand the concepts of malignant glaucoma. We have a constellation of shallowing of the chamber associated with choroidal expansion because of a thick choroid. Vitreous pushes forward. We lose the conductivity of vitreous. And we have not enough space around the lens to re-equilibrate and balance the positive pressure. The answer in these cases is typically do a unicameral eye. These patients do not need a full vitrectomy. However, doing an iridozonular hiatal vitrectomy, making an opening in the iris and the zonules, is typically what we need to do here. Of course, we can also use pars plana incisions in this case, but I will warn you, in these very small eyes, be very careful because the ora serrata may be up to 2.5 millimeters from the limbus. And if you make your incision 3 millimeters from the limbus in these small eyes, you may enter the retina. So I really like to avoid pars plana incisions. If I have to, I'll go very anterior, but then we risk hitting the lens. Instead, we use mannitol and we soften the eye up. What about lens choices? Well, these patients require very high diopter lenses, and we don't have the best formulas, but we use typically Barrett and Olsen formulas typically. Do not piggyback these patients. These eyes are too small, in my opinion. I don't like piggybacking these eyes. I'd rather have a single lens, and we have a variety of choices. The Human Optics Aspira lens is the best lens, in my opinion. It's a hydrophilic lens. It can go up to 60 diopters. You can see the special order all the way up to 60 diopters here, and that's what we like to use. We also need to look for synechia, and I am a believer of doing going to synechiolysis. I know the opinions are variable, but we summarized this in an editorial that I wrote in Ophthalmology Glaucoma last year or earlier this year that I recommend that you can read to see what our results are or what the interpretation is. Like I said before, having a gonial lens intraoperatively is very handy. This allows us to look in the angle. And as an example here, you can see PAS formation into the angle. And it's very nice to use this lens and use a pair of forceps, as you see here. And the forceps directly viewing the angle, we can nicely peel away the synechia. I don't like leaving PAS on the table if I'm in the eye doing cataract surgery and angle closure. I believe we should be looking in the angle. We should make an attempt at this. This is low risk. And if the patient has more than 4 or 5 clock hours of PAS, I think it's worthwhile to release it. Smaller amounts are not necessary to release, of course, as the angle can open with the rest of that. This is the patient here. In these very small eyes, you can see 10 millimeter white to white, 16 millimeter axial length, 1.9 AC depth. The chamber is very shallow here. And like I said before, I don't like to do a partial incision. However, I do like to do a posterior sclerectomy. This is because we do have patients who have a problem with uveal effusion, either before or after surgery or intraoperatively even. And the sclera is so thick, you can see here, we're going back about 5 millimeters from the limbus, going all the way down to the choroid there, and basically release any fluid and make a window. Because this will protect us from post-operative effusions, which is a certain risk in these very small eyes. I think this is really a good idea in very small eyes. Typically, if the eye is less than 18 millimeters, I like to do a sclerectomy, and maybe I do 2 if there actually is an effusion. A punch is used to make the window, and there we see the opening there. We can now pay attention to the anterior chamber, very shallow. The patient has been given mannitol. We may have a Hohmann balloon to soften the eye up even. We do not do blocking. We do not block these patients, however. It's either topical or general because we don't have to block a patient and cause more positive pressure. The chamber is very shallow here. We will carefully keep the chamber formed. We will use some super viscous Helon 5. And we're lucky enough to be able to do the capsulorhexis and do the procedure reasonably well despite the chamber being shallow. It's a soft lens. We will do our phaco, but very importantly, before we come out, we do not let the chamber shallow. Let me tell you how critical that point is. If the chamber shallows in a small eye, we really, really seriously risk developing worsening positive pressure, worsening malignant glaucoma, or an effusion. So very important to do that. We will put the lens in the capsular bag, suture the incision, and now we're doing the iridozonulo hyaloid vitrectomy. This is basically making a unicameral eye. This is to prevent and treat malignant glaucoma. Just take a look here and see the chamber is still shallow. It's still positive pressure. We do an iridectomy. The iridectomy should be a good size, not a small iridectomy, but a good size iridectomy. We don't want the iridectomy to close, but an iridectomy is not enough. You have to put the cutter and go deeper into that hole, go cut the capsule and the zonules in that iridectomy, go back further, break the anterior hyaloid, and go and remove vitreous. Watch as I break the anterior hyaloid here, pointing the cannula posterior, avoiding the lens, avoiding the ciliary body. This is a blind approach anteriorly, and look how deep the chamber forms now. Look, put the viscoelastic in the chamber just deep. We broke the attack here. We just removed a small amount of vitreous. And then we will do our going to synechiolysis to remove all the synechia in the angle here at the end of the case. And while I'm there, I also put a couple of eye stents in. Why not? Sometime, even though we do a going to synechiolysis, the angle may not function well enough. and doing a couple of trabecular micro bypass shunts or stents, I think, is not a bad idea and very safe to do. I don't like to do trabeculectomy in these eyes from the beginning. I think it's a disaster if you try to do trabeculectomy in these cases early on. I think get the lens out and manage that as well. Here's the post-op result here, as you can see, and we have a good approach there. So in angle closure, in these cases, we have potentially serious complications. As I mentioned, we need to address the two most problematic issues in these eyes, which are uveal effusion and malignant glaucoma. I like to avoid filtering surgery by any means, and I like to do lensectomy with a sclerectomy. Space maintenance is important. I avoid part-fin incisions. For eyes less than 20 millimeters, I routinely do a prophylactic iridozonular hyalodectomy, typically an anteriorly to make a unicameral eye to prevent malignant glaucoma, because the rate of this is pretty common after these eyes have surgery. For eyes that are less than 18 millimeters, I do a prophylactic sclerostomy as well, because this helps to relieve the potential risk for effusions in these thick sclera eyes. So I wanted to just share those difficult cases for you. This is a picture in Toronto before COVID, and I hope you have a chance to visit. But before that, please keep in touch. Always like to hear people. Zeros and I have been talking on Instagram, so thank you for touching base with me as well. And many of you, it's great pleasure to be able to share and to learn from each other. So thank you for listening here. I'm happy to take any questions, or maybe I can go to my next talk. You guys are tired and sick of me already, or no?
No, please, you can continue with the talk first, Dr. Ike, and we'll get to the question and answer after all the three speakers.
Okay, sounds good. I hope I'm not boring you listening to my monotonous voice all this time.
Not at all. Always a pleasure.
But thank you for listening. Okay, let's get to my next talk. Now, my next talk, I just changed the title a little bit here, and what you'll see here, I think it's an interesting thought I had was, 10 cases that I'm going to share with you that I would probably have not gone to the operating room for, or I would have done something different, and maybe I'll explain why this may be the case. Again, my disclosures are here. So, around the world, and I also noticed as well with JEC, you do a lot of different procedures, right? You can do canal procedures, goniotomy, trabeculotomy, eye stent. You can do bleb procedures with micro stents or micro shunts, or trabeculectomy is our classic, or a tube shunt like an Ahmed valve or Bear belt. And then there's cycloablation like micropulse. And these are all options we have on the table. It's great to be in glaucoma these days to have all these options. The American Glaucoma Society has a position paper on MIGS. I think it's a nice way to lay it out. On the left, you see MIGS. On the right, you see traditional surgery. MIGS can be based on non-bleb or bleb procedures. And non-bleb, we have inflow or outflow. Outflow, we have suprachoroidal, and we have trabecular meshwork. Suprachoroidal right now, not so available. CyPass has been withdrawn from the market. And canal-based procedures are what we typically do working in the canal. We then have bleb procedures that we have ab interno devices like Zen. On the traditional side, we have ab external procedures that are forming blebs near the limbus, and those that are equatorial. And we have, again, implants without reservoirs and implants that have no implant and ones that have implants. Trabeculectomy, of course, is our classic group here. So this is a case I want to share with you, which is not uncommon here in Canada. A patient who has left visual field progression. The pressures have been fluctuating in the mid-teens, and the patient's had multiple lasers, and the surgeon says that they are not convinced the patient needs surgery, but they think long-term they probably need surgery. I mean, that doesn't make sense, right? If they need to have surgery, they need to have surgery. The patient is losing vision, and if the patient's young enough, 68 years old, in a few years, they will have more vision loss, and it's irreversible. So this happens because, of course, we have loss of confidence, and we operate late, and then we have more complications, and we have other problems. So we need to break the cycle. This is kind of where we have tried to move forward with MIGS or interventional glaucoma. I'm not going to tell you this is perfect surgery. There are limitations of what MIGS can do. There are costs. But in general, we are working in a less invasive approach in these options, in general, what we're trying to achieve here. And we can do this again, like I said, trabecular meshwork, suprachoroidal, or subconjunctival. Obviously, subconjunctival are more powerful, but MIGS in the canal is very safe. And we have so many options available to us. We have procedures that are basically using a suture like GATT, which can be done with a few dollars. And we have stents that cost $1,000 or more that can be placed in the canal. Is one better than the other? Well, there are still need for more data. We can debate which one has less invasiveness, less bleeding, less trauma, but they all generally work the same way by basically removing the area of resistance or bypassing the area of resistance by using cutting approaches or other approaches. For most procedures like this, typically these pressure targets are more in the mid-teens, often combined with phaco. We also have a new generation of subconjunctival procedures. These are basically more standardized bleb procedures, and two procedures that I do a fair amount are the Zen and PreserFlow. I will say both these procedures are more potent than MIGS. We don't have to call them MIGS. You know, these are really more like bleb procedures, but they're more controlled and less invasive than trabeculectomy or tube shunts. Let me talk about the younger patient maybe who has more than mild disease with a pressure of greater than 15. These patients are not in terrible shape. You know, their pressures are in the high teens. And I think often in the past, we would basically watch this patient. Now, I just said right now, this patient has more than mild disease. This patient has, like, you know, real disease. I'm not talking about hypertension. I'm not talking about, you know, a small visual field defect. These patients have real disease, right? More than mild disease. You can see the RNFL loss in this patient. For a 55-year-old, if we're going to keep this patient's vision for the next 30 years, I don't think keeping patients whose pressures are running 16, 18, 19, I think is enough. Many of us settle for it. And if the patient was 80 years old, I think we're okay with that. But my point is that these patients have serious structural damage. Now, our guidelines in Canada would say this patient has mild to moderate disease. Keep the pressure around 18, you're okay. But I really feel that I think we need to move forward and understand that I think the lower we can get, the better. Even for mild disease, like in the Canadian glaucoma study, keeping patients' pressure less than 15 resulted in less progression over 5 years compared to those that were higher than 15 or 17. This is not for advanced glaucoma. These are even for milder cases. So what do we do in these cases? Well, we could do MIGS, but MIGS doesn't get us low enough for these patients. A trabeculectomy would, but they're higher risks. Tubes, safety, big hardware though, and less pressure lowering. But this is where I think subconj MIGS like Zen and PreserFlow have, I think, a really good option here. And so in these cases like this, for example, I have had good success. Here you can see me using the Zen implant, placing the Zen in the subconj space. There's a lot of different nuances here. This is a procedure that is not so simple because getting the needle placed just right is really important to make sure that the Zen implant is not caught in tenons. Many of us now open conjunctiva and put the Zen in as an open approach, which is fine as well if you want to do this. But I do like the value of the controlled flow through this lumen with a posterior bleb. I think it's really worth it as an advantage in doing something safer than doing, a trabeculectomy. And there you can see we put some mitomycin in as well. We always use mitomycin. These are bleb patients. And we have a nice bleb. So this is a patient here where maybe before I would have maybe not necessarily done surgery on this patient. Patient 17, 19, what's the big problem? But I do believe this patient is going to be at risk if we leave this patient alone. And trabeculectomy might be too aggressive. Subconj MIGS, I like the idea. Okay, we got a lot of 95-year-old patients in our practice now. And before we used to leave them alone, right? They are high risk of having complications. And my goal is, how long do I need to have this patient seen for? In the older days, patients didn't live this long. They live long though, right? These patients here have a lot of issues and questions. And we have to think about life expectancy. Once they live past the age of 80, they have a good chance they're going to live for another 10, 15 years. Now, we don't need to have a very low pressure. We just need to get pressure controlled into a reasonable way. And I don't like doing trabeculectomy in these patients. I typically do, for example, an Ahmed valve. I like the Ahmed valve in older patients. I think it's safer. I also, depending on the disease, will also do a GAT procedure, because a GAT procedure you can do anywhere in the world, including in Indonesia. All you need is a 5-O-proline suture, an MVR blade, a 25 gauge needle, and a low temp cautery. You do need a microforceps of some nature. And you can see basically by using a low temp cautery to create a round nose tip, this facilitates movement into the canal. We go in, we make a goniotomy here. There's the goniotomy made. We pass the suture into the goniotomy with the assistance of a microforceps, bend it into the canal and then pass it. We can do 360. In this case, we're doing 360 all the way around. We'll grab the tip, we'll pull the suture out, and we create a 360-degree goniotomy. The other alternative, which I do mostly for older patients, I only do a 180 degrees. So here I made a goniotomy. We're going to pass the suture, but we're going to only do 10 good pushes. 10 good pushes. Once we get to 10, we feel resistance. Look at the suture starting to bend. This is typically tells us we've gone 180 degrees. We stop. In my opinion, in most older patients, when we do this procedure like abdominal trabeculotomy, we don't need to do a 360-degree goniotomy. 180 degrees is enough, and you can see we'll basically pull the suture, and there it is, 180 degrees apart. So I do like to use this procedure for these older patients. What about juvenile glaucoma? Of course, in congenital glaucoma, we do goniotomies all the time. But even in juvenile glaucoma or uveitic glaucoma in a younger patient, we have had tremendous success, honestly, by doing, again, an ab internal trabeculotomy. Even when the pressure is 35 on 4 medications, with a patient who's 30 years old, who maybe has uveitis with open angle, we will look to do an ab internal trabeculotomy. Same thing here. Instead of using the suture here, I'm using a catheter and injecting viscoelastic as well. So it's really important, I think, for glaucoma surgeons to be comfortable working in the angle. Whether we do goniotomy or ab internal trabeculotomy like this, we're passing the suture. This is a little bit easier than passing the suture, but of course we have to pay more cost to get this catheter. So you can decide which way is more accessible for you, but either approach is fine. In this case, we're doing a 360 degrees. For my younger patients, we'll typically do a 360-degree trabeculotomy. We grab the distal end and pull on the proximal fiber, and we do a 360-degree goniotomy. And there you see the canal opened up nicely. So young patients, open angle, uveitis, great option here. Older patients don't necessarily respond to the goniotomy as well as the younger patients do. But it's quite a safe procedure, and you can always do a bleb procedure later on if you need to. Okay, what about this patient here? The patient who has normal visual field, but is progressing, only on imaging. And the visual field hasn't changed because, of course, it's too early. Someone like this who's on maximum tolerated medical therapy, had SLT, we may be reluctant on doing surgery on imaging alone, but I think the time has come where I think really we need to be thinking about surgery in these patients. Often the patients are younger. Because of structure function, we know that function can delay. And of course, we want to have reliable imaging. But these are patients where I look at doing MIGS or subconj MIGS. I don't like to do trabeculectomy on a normal visual field. But doing a MIGS procedure or doing a subconj MIGS, which I believe is safer, I think is a reasonable option. Keep in mind, of course, even subconj MIGS when you have a bleb, you can still get bleb problems, though. And that's one thing we have to remember. That's why we like to do MIGS first line if we can. Okay, what else? Well, I like to do cataract surgery and pseudoexfoliation. I like to do it earlier than later because, of course, it's much better to deal with a cataract that's less dense if the zonules are weak. And we can often, even if the zonules get weak later on, we can deal with the lens and refixate it. I do like to use capsular tension segments and capsular tension rings as I'll show here, in this case of some weak zonules that are mild. And a catheter retention ring, I think, is a nice tool to use in these milder cases. Of course, for more advanced cases, we need to use something we can suture, like I showed earlier, with catheter retention segments. And putting a ring in now nicely supports the bag. We can do our phaco, the lens goes in, and we have a well-positioned lens that is stable. Despite this in pseudofilation, we can still get lens dislocation. Now, I'm sure in Indonesia you still have pseudofilation. I don't know, it's probably not as common as other places, but I know you can see this. And so we need to be prepared that these patients may still get dislocations. And be prepared as a glaucoma surgeon. You will see this. Patient has IOL dislocation with high pressure. Well, we can deal with the lens by refixating the lens to the sclera, by passing the suture around the haptic through the bag, creating a loop. We use the fibrous capsule to hold the suture in place. We make scleral passes here in order to secure the lens to the sclera. Again, I'm using Gore-Tex here. This is a very nice, elegant approach using small incisions. And we often combine this with glaucoma surgery. Again, I typically use tube shunts in these cases. I find trabeculectomy to be less controlled. The other thing I'm doing a lot of, when I have a patient with cataract surgery who has glaucoma, I typically do mixed procedures with the patient. Although we know cataract surgery can certainly lower pressure, combining with MIGS adds additional pressure lowering and reduces the need to go on to more surgery. I have patients like this who are older, they're pseudophakic, they're not severe, but they're having trouble with drops, they have ocular surface issues, and they have problems with their drops. I like to, again, approach these patients interventionally, and again, we will do mixed procedures. Finally, the normal pressure glaucoma patient who's progressing. One thing I like to do in these patients here, this patient's progressing. Look at the right eye. They're getting worse in the right eye. And the imaging, same thing. I do like to use home tonometry. Home tonometry I find to be very useful. And we can see this patient's office pressure is 12, but yet they're fluctuating at home. And this helps us because I use home tonometry and I use water drinking test. I don't know if anybody does water drinking test. I like it a lot for people who have normal pressure glaucoma who are getting worse. Because, for example, the patient on the top here, you can see here, for example, on the top, the patient whose pressure is 12, but when I do home tonometry, they're up and down, and water drinking test is 24. Well, this patient does not need a trabeculectomy, right? This patient would be better off having a subconj MIGS because I don't need to get a pressure of 8. I need to get a pressure of 12, 24 hours a day or 14, 24 hours a day and break the fluctuation, okay? On the other hand, if we have a patient who is, for example, on the bottom, you see here, where on the bottom you'll see that we have, even the pressure is 12, but even at home, they're 12. And the water drinking test you see here doesn't go up very much. These patients need a trabeculectomy. So I like using home tonometry and water drinking test to help me differentiate whether I'm going to do a subconj MIGS or a trabeculectomy. Even though the office pressure is the same for both patients, it's the out-of-office pressure, which is what the problem is, and either water drinking test, which is a stress test for the eye, or home tonometry are both reasonable options, I think, to assess this. So I do like to use pressure beyond the office. I think office pressure is not a good way to look at this. And you can see this patient ended up having a subconj MIGS. Pre-op, you can see the pressure fluctuation, and post-op, we see the pressure fluctuations have reduced. And in these cases, we often, for example, do procedures like this. This is a pressure flow device, very beautiful bleb. And the control of this device, we have been very impressed with using mitomycin with the in-focus or the pressure flow device, which I think has become one of our most potent procedures. This is particularly helpful for patients who are high risk, for example, like patients of hypotony. So those are some quick cases I just want to share with you of cases maybe where in the past we maybe have chosen a different surgery or maybe not even done surgery for, but with our new options here available to us, something to think about as far as the options here. So thank you for listening to me all this time.
Okay, thank you, Dr. Ike, for the wonderful and marvelous presentation with the breathtaking surgery. And I think we can all agree that managing advanced glaucoma can be very challenging, and it's encouraging to know that in the future we can have more safer ways to control advanced glaucoma. Okay, so we're gonna proceed to the next speaker, Dr. Emma. Dr. Emma will share her experience in this case presentation. Dr. Emma is a glaucoma specialist in JEC Eye Hospital. She has done fellowship in Rotterdam Eye Hospital and Tokyo University. Dr. Emma, you have 10 minutes to deliver your case. The floor is yours.
Thank you, Dr. Vira. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
So, good morning, everyone. Today, I would like to present one of the case I found in the outpatient clinic. So, this is a case of a female, 71 years old. She came to the hospital with chief complaint of pain and blurry vision of the right eye since 1 month ago. She underwent the cataract operation 1 month ago in the other hospital. After the operation, she couldn't see clearly and slowly developed pain in the right eye. She was then referred as a pseudophakic glaucoma that was unresponsive to oral acetazolamide, latanoprost, and beta blocker. There was no history of trauma or systemic disease. From the ophthalmological status, she had a visual acuity of 1 meter finger counting with refractive surprise, spherical equivalent minus 3.75 from the objective refraction. From the cornea is mild edema with diffuse flat anterior chamber. We can see here. Yeah. The pupil was round, mid-dilated without any light refracts. And from the lens, we can see that the IOL was pushed forward. From the fundus, we can see that there's a large optic nerve cup. From the left eye, we can see that there's a mild cataract with occludable angle and also a large optic disc nerve cup. Okay, so Dr. Ike, we will do some kind of voting here. So what is the most probable differential diagnosis for this patient? Is it pseudophakic pupillary block, pseudophakic malignant glaucoma, acute primary angle closure, or suprachoroidal hemorrhage?
Everyone gets to vote now?
Yes, it's kind of interesting to see. Okay, I think we can end the poll. So most of you answer with the pseudophakic pupillary block. Yeah, I diagnosed this patient with the pseudophakic malignant glaucoma because we can see there's no pupillary block, there's no synechia, and actually pupillary block kind of very low incidence in the pseudophakic patient. So I decided to hospitalize this patient, put on the IV mannitol, and give her 4 classes of anti-glaucoma medication with together with cycloplegic and oral carbonic anhydrous inhibitor, and then the IOP lowered down to the 40 millimeter mercury. So the next polling, what should we do next? Will you do the NDX laser capsulotomy or trabeculectomy, or go straight to the vitrectomy? This is the second polling for this case. Okay, another 10 seconds for the polling. So most of you answer to do the trabeculectomy immediately.
No.
Yeah, but the next day, I decided to do the NDX laser capsulotomy. Actually, this is the easiest way, I think. So I tried to do the capsulotomy as large as possible. And I can see that the anterior chamber can deepen immediately, especially in the center. And the patients felt more comfortable, but the IOP was still not significantly reduced. Still like 36 millimeter mercury, and the visual acuity improving to 3 meters finger counting. So I completed the examination. From the examination, anterior segment OCT, we can see that there is a forward displacement of the iris line diaphragma with large area of iridocorneal touch. And the left eye was confirmed angle closure. From the fundus, we can see both eyes had a large cup, glaucoma cup. From the OCT and ganglion analysis, we can see that this is a quite advanced glaucoma in both eyes, and then it was confirmed with the visual field severely damaged in both eyes. And this is the last polling for this case. What will you do next? Will you do the traps, or will you go straight to the pars plana vitrectomy, or maybe you can consider doing a cyclophotocoagulation procedure? So most of you answer yes. To do the traps. Well, that's the next step that I will do. So I decided to do the traps because of the antechamber is started to form only in the middle. So actually this is a regular trap because we're dealing with the high IOP. I started the trap with paracentesis of the AC to lower the IOP gradually and give us access to the antechamber. Then continue with regular trap. I made a quite large iridectomy, reformed the AC, and in the end of the surgery, I tried to release the synechia. Okay, so this is still the iridectomy. I made a quite large iridectomy, and then once again, reform the AC. Unfortunately, the AC quite formed in the end of the surgery, and I tried to release the synechia with the viscotip. And fortunately, the next day, the IOP lowered down to 14 millimeter mercury, visual acuity 0.05, and the AC is well formed. And this is 1 month after the surgery. Visual acuity improved to 6/20, AC remained deep, IOP is 15 millimeter mercury without any anti-glaucoma medication. And there was no significant IOP rise or shallowing on the anterior chamber in the last 5 months follow-up. So when we're talking about the pseudophakic malignant glaucoma, like Dr. Ahmad said, actually it was quite rare. In one study, they mentioned that the incidence was only 1.3% of all the intraocular surgery. It usually occurs during uneventful phaco in hyperopic eyes. It might be very subtle during phaco. We might notice it while finding difficulties in completing the IA or inserting the IOL because of the diffuse shallowing or flattening of the AC. Sometimes we call it the acute intraoperative rock-hard eye syndrome. So the treatment goal to create communication between the anterior chamber and the vitreous. Usually after we failed the medication, we continue with the NDX laser capsulotomy to disrupt the anterior hyaloid membrane. NDX laser alone can effective in almost 50% cases, and in cases it's not working, we can continue with traps, but the definitive treatment was vitrectomy. We can do vitrectomy through pars plana, or like Dr. Aik Ahmed mentioned before, from the clear cornea together with doing the iridozonulohyalodectomy to create a unicameral eye.
Excuse me, Dr. Emma, you have 1 minute left.
So as a conclusion, before doing a pseudophakic malignant glaucoma continues to be one of the most difficult types of secondary glaucoma to manage. Typically occurs after phaco in hyperopic eye or concomitant chronic angle closure glaucoma. Treatment goal is to create communication between the AC and the vitreous, and care should be given to the fellow eye before we doing any intraocular surgery. Thank you.
Okay, thank you, Dr. Emma, for the wonderful case. I'm sure Dr. Ike has some thoughts on that case, but we have to proceed to the next speaker first, and then we'll address the discussion after the last speaker, okay? So the next speaker is Dr. Zeras. Dr. Zeras is also a glaucoma subspecialist in JEC. He has done fellowship in SNEC. Please, Dr. Zeras, the floor is yours.
Thank you, Dr. Vira. Can you hear me clearly?
Yes, Dr. Zeras, please.
So for this case presentation, I would like to share a case that I think we as an ophthalmologist may encounter in our day-to-day patient, and we have to deal with it in the best interest in our patient. I have no financial interest. So the patient was a 46-year-old female, was referred from another ophthalmologist with history of glaucoma attack 3 days ago. There was pain and blurred vision on the right eye. In the referral letter, it was noted the VA was 1 meter finger counting. She was told to have IOP of 40, given meds, and referred for surgery. So on examination, we found the VA was somewhat improved to 0.3 BCVA. IOP came down to 7. The cornea still a bit edematous, probably from the previous attack, and the AC was shallow with slit lamp examination and gonioscopy. The left eye was open, she had cataract, and the lens was bulging forward. We diagnosed the patient with phacomorphic glaucoma. So before we continue, I would like to inquire our fellow ophthalmologists. Do you routinely do gonioscopy examination on a new glaucoma patient? So we may have a poll now. So not all of our attendants are glaucoma specialists. We would just like to have a rough estimate on how many of you do gonioscopy routinely. So I see that most of our colleagues do them, but still only half of all the attendants perform gonioscopy routinely. So in this case, I would like to highlight the need to do a proper angle assessment on both eyes, since to differentiate between AP-AC. In phacomorphic glaucoma, we usually see a shallow angle in one eye and open in the other eye, such as in this case. If the other eye is also shallow, then we might have to treat this as an AP-AC, and PAC or PACS on the left eye, and might have to do prophylaxis PI on the other eye. There are many options on goni lens, and my go-to lens is 4-mirror, which is I find much simpler without the need of coupling gel, and we can do indentation gonioscopy with it. But sometimes you do with what you have, such as in this video, I'm using a 3-mirror lens. So recognize the landmarks, wobble line, trabecular meshwork, scleral spur, then ciliary body. And do a proper assessment on all 4 quadrants. So we can also use a anterior segment OCT to assess the angle, which is a great way to objectively document the angle. With this, we can show the patient pre and post treatment what we have done for them, but it does cost more for the patient. UBM can also be used to assess the angle, and if we are worried about zonal dehiscence, we could use UBM examination to see whether there's a zonal lysis or not. It will help us prepare better in preparing for surgery. Treatment option, we can use beta blocker, corbinic anhydrase, alpha-2 agonists. Pilocarpine are usually contraindicated because they can produce paradoxical effect of shallowing the AC. Hyperosmotic agent can be given if the IOP is still high. You can do laser PI to remove any papillary block component, but the treatment of choice for phacomorphic glaucoma is cataract surgery. On biometry, the AC was shallow. We did endothelial cell count on the right eye, and it was 2,216. Several things to consider before surgery. Check for IOP pre-op. If it's high again, you might want to add lowering agents such as acetazolamide orally or mannitol IV. It's a shallow AC, so you can consider a long tunnel. If necessary, you can do second fourth first to inject dilating agents and viscoelastic to deepen the AC before you make your first incision, your main incision. Endothelial cell count is still okay in this case, but if you don't have the tools to count it, you do have to have a careful look at the cornea and balance the risk of surgery. Make a thorough informed consent if necessary for the risk of persistent corneal edema post-op. Prepare for zonal weakness with CTR if necessary. And for anesthesia, we don't generally use general anesthesia unless very, very necessary, especially during COVID, where general anesthesia have an increased risk of COVID. Usually I put the patient on the brightest light during slit lamp or do immersion biometry just to test whether the patient is cooperative enough for surgery. And if it is, I'll do topical. And this is the video for the operation. So I did my main incision and inject trypan blue. As I inject the viscoelastic, you can see how it helps flatten the anterior capsule of the lens. The CCC was done slowly, and you can see a bit of wrinkling in the anterior capsule. And then I did a hydrodissection. Usually in phacomorphic glaucoma patient, the cataract is quite soft. The phaco was done in a low parameter setting. I use a stop and chop technique in this patient, and I remove most of the cortical material first to make more room in the AC before I make my groove. Just going to fast forward a bit. So after I did the crack of the lens, I rotate, and because it was soft, I choose to make another groove and then divide it and continue with the phaco. Okay. The rest is a usual phaco. Finish it up slowly. And again, as mentioned before, whenever you take out of the phaco tip, make sure you put in the viscoelastic first to reform the AC to prevent it from collapsing. During this IA, I noticed and felt uncomfortable on how the capsule was moving, so I decided to put in the CTR. And after that, continue with the IA, the IOL placement, and finish. So one day post-op, the visual acuity was 0.2, pressure was 15 without any medication. The cornea was slightly edema. The pupil was still dilated, and I add carpin 2%. For 1 week, it was 1.0 BCVA with good IOP and minimal inflammation. The angle was open. I continue the medication, and I hope to see the patient one more time before I send her back to the referring doctor and ask the patient to come back again in 2 weeks' time. But then we have COVID, and due to travel restrictions, she was unable to come to our hospitals. So the take-home message is always assess the angles, plan your surgery, consider all aspects pre-op and intra-op, and early treatment can really prevent permanent glaucoma damage. But now the patient come back again in 4 months later. Visual acuity is still good, IOP is still okay. But then the problem is, as you might have guessed it, she felt that there was glare. It was a fixed dilated pupil. She admitted that it doesn't bother her much, but it must be noticeable enough for her to come back and see me again. I explained to her that this might be due to the glaucoma attack, and her option would be glasses, contact lens, and surgery. She's not keen for surgery, so I did try her on carpin for a few weeks, but it has not changed much. And finally, we agreed on glasses. So, question, in hindsight, what you have done to help constrict the pupil? So, Dr. I actually choose this patient because I've seen your webinar on how you do the pupillary encircle collage. I was hoping to do it on this patient, but she refused to do it. So I would like to have you elaborate more on that technique as you have shown before. So, okay, we can end the poll, and most of you will add my stat. Some will have done 90% done pupilloplasty on the spot. Okay, we can close the poll. So thank you. I think that's all for me. Thank you, Dr. Fira.
Okay, thank you, Dr. Zeras, for the great presentation. There are some questions, but Dr. Ike already answered them in the Q&A box. So I think we can proceed to the discussion for the first case, Dr. Ike, about the pseudophakic malignant glaucoma. So what's your thought about that? Would you do anything differently?
Yeah, it's one of my favorite topics. Emma, thank you for presenting that. I think that was a really instructive case to talk about. You know, doing a capsulotomy, of course, is the idea essentially is to create a unicameral eye. And I imagine that you probably laser the capsule, and also you should try to laser the anterior hyaloid and this way we have a communication. Laser in the posterior capsule may not be enough, however, if the aqueous cannot come into the anterior chamber. So, for example, if the anterior capsule is fused onto the optic, then only laser in the posterior capsule may not be enough. So I typically always make sure I go through the anterior capsule and the posterior capsule and the anterior hyaloid, and make sure that I get full thickness all the way through. Sometimes it can be through the iridectomy, or sometimes it can be if you dilate the pupil big enough. So that's one thing, and I mean you had a great result. The problem is, of course, when you have someone with persistent shallowing, you have angle closure now, and you have synechia. And so in that situation, what I typically do is I try to address the synechia first, and I use either at the slit lamp or in the operating room a needle or a forceps to release the synechia, with or without vitrectomy if need be. And that's usually what I do next before doing trabeculectomy. I have to say I don't like trabeculectomy if I don't have to. Leaving a patient with a bleb is something that long-term is always a risk. And so I try doing that first, and then only after I have an open angle and the pressure is still high do I consider doing a bleb procedure. So that's kind of what I've done. Of course, hard to know. I mean, your patient, if they have more advanced disease, you may decide to say I need to do a bleb, but the problem in malignant glaucoma, if we don't open the angle up at the same time, just like doing phaco, if we do phaco and the angle is still closed, then the pressure may not come down. And so it's something that, just to consider. But these are tough situations. I think you have a great result. Many people, it's called malignant for a reason. Malignant is bad, right? And you were able to save the patient. So this is a very good thing.
So actually, Dr. Ike, I have one question. I saw your video about when you do the anterior vitrectomy and you also create the iridozonulohyalodectomy. And it was kind of nervous to see that video because you're doing the vitrectomy anterior with blind procedure, right? Mm-hmm. And you're in the vitreous space is the easiest area where you can easily get retinal tear. So how to avoid that?
Actually, I actually think it's a very safe area to be in, because you're really in the anterior vitreous, and so it's important, of course, not to put the cutter toward the ciliary body. You're not going to be near the retina because we're only going back just behind the capsule, and then we cut the zonules, cut the capsule, go a bit farther, and then stop. I do agree with you. It's a little bit nerve-wracking because you can't see the tip, right? Yes. You can also do this, by the way, pars plana as well. You can go pars plana and come this way, but then your pars plana incision, if it's a very small eye, you may be entering anterior retina. That's where it becomes more dangerous, making a pars plana incision when you have an anterior retinal insertion in a small eye. So, as long as it's all about how you angle the cannula. If the cannula is pointed between the angle and the IOL, then you have a good approach to go in there. So that's what I would say. But yes, it is something that is a bit nerve-wracking because you can't see your tip. But actually, you're just removing a small amount of anterior vitreous, and so it's like if you broke the posterior capsule. That's what broke the posterior capsule. You put a cutter behind the capsule, do vitrectomy. You can see it though. That's the difference. Otherwise, you're still removing vitreous in the same place. It's just more peripheral. So that's why I feel that it's still safe. But as long as you don't put the cutter and touch the ciliary body, the biggest problem is hit ciliary body, you get bleeding. It's not so much retinal detachment; it's more that you hit or you go vertical and you make the lens dislocate because you make vertical like this. You have to be like at a 45-degree angle. So that's what I would say.
Dr. Ike, I think I saw Professor Keith Barton doing sclerostomy posterior for this kind of cases. What do you think about that? Do you think this can also manage with sclerostomy posterior?
That will not resolve malignant glaucoma, though. It will not. It will not. And so that's where I do B scans a lot, because the B scan will help me to tell me whether there's an effusion, a choroidal detachment, or a thick cord. I don't know, Emma, what the axial length of your patient was. Was it a short eye? The axial length?
Short eye.
Probably, yeah, short eye. So, but I'd like to do B scan. If you can get a B scan or UBM or B scan, it's so helpful in these eyes to know what's going on back there. Because if you have an effusion, then absolutely do a posterior sclerectomy. But if you don't have an effusion, you do sclerectomy and you have malignant glaucoma, that's not going to help you. You need to do a unicameral eye. because that's the only way to deal with. In these malignant glaucoma cases, these cords are so thick that even spherectomy isn't enough. You have to basically get some vitreous, and you have to basically create a unicameral eye. So that's what I would say.
Yes, thank you, Dr. Ike. And do you have any tips or tricks to prevent this catastrophic event for occurring for the next eye, for the fellow eye, I mean?
Yeah, I mean, don't let the chamber shallow during the case, number one. So important. Any kind of shallow when you get a hard eye. And like I said, if the axial length is less than 20, I go ahead and do an iridozonular hyalodectomy. I just do it prophylactically. And so that way I prevent it. If you're not sure, and you're not sure should I do it or not, I recommend doing a good iridectomy. Do a big iridectomy. Because after surgery, if there's a problem, now you can do the laser through the iridectomy, and you can do the same thing. You can do a laser zonulohyaloidotomy by lasering through the iridectomy. But the problem is, as Emma saw, I mean, when the chamber is shallow and the flat, you cannot laser through the iris. You got to laser the capsule. And you're lucky that you're fortunate it worked out for you. But sometimes even lasering the capsule isn't enough, because the goal of lasering the capsule isn't doing a capsulotomy. The goal is to create a unicameral eye. So if aqueous can come through the capsule into the anterior chamber, perfect. But it doesn't always do that, because the IOL is maybe blocking it, or the capsule may be fused. And that's why doing a peripheral laser might be more useful. But yeah, prevention is to do a surgical iridozonular hyaloid vitrectomy. I tell you, every year, I'm not kidding you, I see or treat, I would probably say 20 to 25 malignant glaucoma cases. After TRABs, after phaco, we published 20 cases a few years ago, phaco alone, simple phaco. And you know what? They were all female, by the way, all female with short eyes, hyperopic eyes. Interesting enough, there's something about women, right? I'm not going to say anything, but something about women that, there's a predisposition to this. And there's been a lot of discussion on this, of course, with angle closure, we know as well.
Okay. Dr. Ike, there's a question from the audience. On nanophthalmos with high IOP, do you usually keep them on atropine post-procedure? If so, how long? And secondly, on combined cases, on those cases, if we don't have mix, should we combine cataract surgery with tube or trap?
Yeah, so I basically think atropine, yes, can be used. In fact, it can be used to treat malignant glaucoma. Sure, the first thing that Emma did is she put them on aqueous suppression, put them on acetazolamide, and even atropine to help that. So yes, it can be done. I don't like keeping people on atropine chronically, because once they stop it, the malignant glaucoma can recur. So I think it's useful as a temporary measure, but not a long-term measure. And I think the long-term measure is you need to treat with a unicameral eye. Sometimes you can get away with, post-operatively, you treat the malignant glaucoma and then things stabilize and then you're okay. But I think that it's not a long-term solution. So I do like to get the laser done or surgically do that iridozonular hyaloid vitrectomy if needed, is what I would say. And again, it's these eyes that are not only short, 20 millimeters or less, but even eyes that are longer than 20, but have an anterior chamber depth less than 2.5 millimeters. I'm talking about from the epithelium, right? These eyes also are at risk. So you have a 22 millimeter eye, 23 millimeter eye, and the AC depth is 2.2 millimeters. And it's not because of a big lens, it's just a small anterior segment. White to white is 10.8 millimeters. That eye is also at risk because it's got a very small anterior segment. So the aqueous cannot properly go from the front to the back of the eye like it normally can through the zonules.
Okay, thank you, Dr. Ike. There's another question from Dr. Andika, one of our master of glaucoma in Indonesia. He asked about what about the most feared thing in complicated glaucoma or combined surgery like you do is the incidence of wipeout cases, especially in advanced glaucoma. Is there any clue that which cases will most likely to have a wipeout occurrence, Professor Ike?
Yeah, I mean, I talk about this a lot and I warn my patients. So what I look at, of course, patients who are at risk are a couple of things. One, patients who have a visual field defect that's at fixation, right? It's right at fixation, fixation threatening, usually in the inferior quadrant, right? Our fixation basically, essentially is in the inferior hemifield. So we can lose all the superior hemifield and still be 20/20. But once you lose the inferior hemifield, our fixation fovea is in the inferior hemifield, and that can wipe it out. So number one, if there's a visual field defect that's encroaching the inferior visual field fixation point, that person's at risk. Patients who are more myopic tend to have a higher risk for snuff out. And of course, patients who have hypotony during surgery or after surgery, or have pressure spikes after surgery, are at risk. For that reason, I really like procedures like, for example, pressure flow. Pressure flow, beautiful post-op result in the first 2 months. Very rare to see pressure spikes in this patient or hypotony. Trabeculectomy is okay, but you can get pressure fluctuations, right? Pressure goes up, suture lysis goes down, up and down, intraoperatively. So that's also a risk factor as well. Tube shunts also can vary. Even MIGS procedures can go up and down. So choosing the right procedure is important as well. The incidence of this in advanced glaucoma is around 5%, but I will say it's higher in patients who have a visual field that's right inferiorly approaching fixation. And again, the patient who has a high pressure, where you're dropping the pressure low, or hypotony. Those ones I tell my patient the risk is 8 to 10%. I mean, maybe it seems high, but I'd rather be overestimating than have a surprise.
Okay, thank you, Dr. Ike. And now I think we'll discuss about the last case from Dr. Zeras about the cataract surgery in phacomorphic glaucoma. Do you have some pearls or pitfalls on those kind of cases, and how to maybe avoid like malignant glaucoma in the future for this kind of patient?
Yeah, well, Zeros, thanks so much for presenting that. I think it's a reminder about gonioscopy, right? I mean, I'm going to tell you right now, everybody here listening, we have to do gonioscopy. It's so important. If there's one thing to remember here, it's the value of gonioscopy. We don't feel complete as an ophthalmologist without doing gonioscopy. Really, it's like not looking at the fundus for a diabetic patient. We would never dream of this, right? We never dream of basically saying, "Oh, patient is diabetic. We're not going to look at the retina. It's probably fine." So you can't do that. We have to do that. I would come and bring 500 gonio lenses with me in my suitcase if I help people to do gonio, because it's so important to do that. So I want to make the first point that Zeros already mentioned already. I saw the vote there that there was 40% of people didn't do gonioscopy, or only do it sometimes. Anybody with glaucoma, I don't care if you think the angle is wide open, we need to do gonioscopy. Not sometimes, but every time. The pressure goes up in somebody, do it again. Post-operatively, do it again, right? So important to do that, and it's very rewarding. Get a Goldman lens, get a Sussman or a Zeiss type lens if you need to. I think it's so important. That's the first thing. And second thing is, yeah, I mean, Zeros nicely went through some of the challenges in these small eyes. I presented this as well in my first talk as well. And I think the biggest thing, again, is don't let the chamber shallow during the surgery. It's so easy to come up with your IA handpiece or your phaco handpiece, and the chamber shallows for maybe 10 seconds. That 10 seconds could basically, I have videos to show you. Everything's smooth. The surgeon comes out of the eye, chamber shallows, go back in the eye, boom, it's rock hard now. And you've got an effusion, or you've got a hemorrhage, or you've got malignant glaucoma. So really important to try to address that. I will again agree that zonules can be a problem. Be aware of that. Think about goniosynechia as well, which I think is important to do when there's a lot of synechia in the angle. And there's a lot, I mean, lensectomy is fantastic for phacomorphic, glaucoma, for lens-related glaucoma. Really a great tool. And you mentioned earlier about doing phaco trabs. I believe that doing a trab without phaco is better than doing phaco trab. So I like to do a phaco first, if I can, see how it goes, with or without MIGS even, or do goniosynechia. And then if I have to do anything like a trab later, yes, it's true, then I will do a trab later. Like I'll wait maybe 3 months or so, because I think it allows the blood aqueous barrier to stabilize.
Okay, Dr. Ike, there's a request for the video you mentioned earlier when you do the operation and then the IOP suddenly went up. Do you have the video right now?
Of which one?
Yeah, the one you mentioned earlier when you do the phaco and then it suddenly just went up.
Oh yeah, you want to see that?
Yes, there's a request from our professor to see that. Thank you.
Okay, yeah, sure. Well, keep on talking while I load it up here. I have it on my computer. I'll bring it for you in 1 minute, okay?
Okay, there is actually a question for Dr. Zeras. I think, is it- or maybe any question from the other panelists?
Yeah, I noticed that you did the pupilloplasty, Dr. Ike. How was the long-term effect on the patient? I mean, the people were small. There was definitely will not be any glare, but how about the long-term effect?
It's fantastic, buddy. I'm telling you, it's fantastic. It's really great. These patients do very well. And I'm going to tell you one more tip for you. One of the best ways to prevent re-synechia of the angle is do a pupilloplasty, because now the iris is pulled away from the angle. This angle, close your eyes, the iris gets very floppy and flaccid and atonic. And even when you take the phaco out, the lens out, the iris can get synechia in the angle. But putting it on stretch is great. Of course, don't make a 1 millimeter pupil. Make it 3.5 or 4 even. You can still look at the retina. You can still visualize everything you need to. The nighttime is okay. And so it's great. Now, the Prolian suture sometimes can degrade. Sometimes it can degrade. And so that's something to be considerate of. But usually the iris is fibrosed around that. So it's generally not an issue. Okay, so you want me to show you some videos again?
Yes, please.
All right. This is like a nightmare, okay? Can you guys see okay here?
Yes.
All right. Let me just there's some music here because it's a nightmare.
1. Ready or not.
Very scary. Okay, this patient here, one of my fellows prepared a 17 millimeter eye, 2.8 millimeter AC depth, pressure is 24 on MTMT. And this case starts off actually really well. There's no, hey, this is looking fine here, right? No problems here. Going to syncytialysis is done. A couple eye stents are placed. It looks okay. And, capsulorhexis happens okay. Doing some viscodissection, CTR in. There's something here now. Look at during the hydrodissection, the chamber shallows and the iris comes out, right? That's not great. We don't like to see this, but the chamber is still formed, and you can see that the iris is put back into the eye, and it goes reasonably well. The phaco goes pretty well here, but I want you to look what happens here. Look what happens here on the left. The surgeon is doing the right thing. They're injecting BSS in the eye, but watch what happens. The BSS cannula comes out of the eye just for a split second. When the surgeon comes out, it goes out of the, right there, see that? And the chamber shallows, just for that split second. So now, as the surgeon is doing the cortical removal, the positive pressure is coming. Now look at the positive pressure here. The eye is getting rock hard. You cannot fill the eye with viscoelastic. All of a sudden, look, it just changed. I mean, even doing nothing, the iris wants to come out of the incision, right? So you see the dramatic change just in a matter of seconds. And before, the iris could go back into the eye, no problem, right? But now, even though the iris is back in the eye, it wants to come out. Look at this force. Look at us. It's nothing. It's happening spontaneously. Things all went downhill here, right? The surgeon should have stopped. So stop here, stop doing surgery, close the incision, and come back another day. But you know what? They're almost there. Put the lens in and you're done, right? You're almost done. The posterior capsule is very convex. So this lens goes right through the bag because the capsule is very convex. There's a lot of pressure. So now you got a lens in the eye and you can't get it out. So, well, maybe remove some vitreous. See if you can reduce that. Try to cut the lens. This is just a mess because there's so little space to work in now. Again, might have been good to leave the eye alone. You can see that the sclerostomy is done here. And now you see what happened there. You see that there was some supraciliary, suprachoroidal blood here. So again, just the point being is that, you get a shallow chamber during the surgery and things can change dramatically. Finally, the lens was removed, sutures placed. And again, it's not a pretty sight. It can happen in 1 second. Another case, one last video. Let me show you quickly here. This case was fine as well, no problem. Lens goes in. Sorry, IA lens is in the eye, not a big deal. You know, chambers deepened up with viscoelastic. This was actually using ECP, endocyclic photocoagulation, and you can see that now after the viscoelastic being removed, the positive pressure is happening, and you can see how the patient's actually now uncomfortable because of the iris manipulation, and the lens is coming forward. So I'm not sure how many people have seen these cases, but I see them too many times. And really, it all happens because the chamber was allowed to shallow during the surgery, even for 2 seconds. In fact, the best way to prevent it is get another viscoelastic in your hand, inject it in the eye before coming out every time. And even at the end of the case, don't remove the viscoelastic with your IA. Remove it manually and leave some viscoelastic in the eye. Put them on acetazolamide or check them out after 2-3 hours. Because if the chamber shallows, look at this. Look at the lens that's sitting up in the anterior chamber. And this is a case of malignant glaucoma, because look what happens as soon as you make a sclerotomy here. This aqueous comes out of the wound here, and some vitrectomy is done. Now, don't do this if there's a suprachoroidal hemorrhage, right? So you got to look at the fundus. Take a 20 diopter lens and indirect and look. Honestly, though, the easy answer, of course, is simply to close the eye. But of course, look at the iris coming out. But now you deepen the chamber. Now you can suture the wounds, and the case is finished off. So just a couple of things to be very careful. Is don't shallow the chamber no matter what. It's a dangerous situation. So there you go, some bonus video for you.
Thank you, Dr. Ike, for another literally breathtaking videos. I literally catch my breath once there. Okay, so I think we are running out of time now. We need to proceed to the next session. This has been a very fruitful and exciting session, and I'd like to invite everyone to give a round of applause for our speakers, although it may be awkward to do this in this virtual meeting. It's been my pleasure to lead this first session, and I would like to thank you again to the speakers, Dr. Emma, Dr. Zeras, and especially again, Dr. Ike. We are very honored for having you here and highly appreciate your time, especially in this holiday. Eid Mubarak to you. And of course, it's already midnight there. So I think
it's 11:30. It's still not midnight. Don't worry.
Okay. So there are still some question unanswered. Maybe if the speaker can answer it directly on the Q&A box. And I think I can conclude this session now. And I shall pass this back to our host, Dr. Rini. Thank you. Assalamualaikum warahmatullahi wabarakatuh.
Welcome, salam. Jazakallah khair. Thanks so much.
Thank you so much, Dr. Vira. So, Dr. Ike, thank you for letting us holding our breath for your awesome cases there. So, we are going to move to another session for our second session. You can stay, or either you can join us for the next session because it's already past midnight your time. We are going to have also a TVC from our sponsor, Cendol, that already sponsored most of our webinars. So please. So welcome back to our glaucoma webinar today. So I saw that Professor Ang Tin is already joined us here today. Before we move to the next session, since all the speakers and all the participants is already here, let's take a photo first, maybe.
Okay. Okay.
Okay, so welcome to Professor Ang Tin. Today, the second session will be moderated by Professor Widya Artini, our glaucoma service, the head of our glaucoma service, and we will have 3 speakers. The first speaker is Professor Tin Ong, the current management of angle closure suspect, lessons from the ZAP trial. And we have 2 case presentation from Dr. Vivin from JEC Candi at Semarang, and also Dr. Dian Arumdini from JEC Java at Surabaya. So our moderator today is Professor Ike or Professor Widya Artini. She completed her fellowship in glaucoma in Lions Eye Institute, Perth, Australia. She also the member of ABGS, IRVO, AAO, IOA, KOA, and IMA. So Prof. Ike, the floor is yours.
Thank you, Dr. Rini. We are now moving on to the second section. Assalamualaikum warahmatullahi wabarakatuh. Good morning. My name is Widya Artini, and I'm the moderator in this section. Joining us for the second session of today's webinar will be no other than Prof. Aung Tin from Singapore. She will give a talk around about current management of angle closure suspect lessons from ZAP trial, then followed by case presentations by Dr. Vivin and Dr. Arum, which we will ask also from Prof. Aung Tin or maybe Prof. Ike, Dr. Ike, to give his expert opinion in discussions. So I would like to, about the profile of Prof. Aung Tin. Wait a minute, yeah. I'm sure that all of you are familiar with Prof. Aung Tin, with his outstanding work. Prof. Aung Tin is finished her glaucoma and anterior segment surgery fellowship in SNEC, and then he gotten his PhD in the University College London. Then he became the professor in SCNC and Yong Lo Lin School of Medicine in National University of Singapore and Duke Nuh Medical School. He's also Executive Director, Singapore Eye Center, Eye Research Institute, and she's world renowned for his groundbreaking work with a lot of research. And then she's member of a lot of society around the world. So I would like to invite Prof. Aung Tin. Hello, Prof. Aung Tin. Nice to meet you again. Yeah, I would like, hello. Yeah, I would like, please, Aung Tin, to share your presentations. Time is yours now. Yeah.
Thank you. Can you hear me?
Yeah, yes. I can hear you.
Thank you. Selamat pagi, everyone, and Selamat Hari Raya. Very nice to be speaking to you for the JEC Symposium. And I'd like to thank Dr. Ike for inviting me to share a talk on the management of angle closure suspects, lessons from recent trials. So I have no disclosures. I come from Singapore, and this is the view of Singapore in the last 2 months with COVID. You can see it's very empty. Usually it's very crowded and lots of people everywhere, but we had 2 months of almost like a lockdown period, and you can see how empty the streets were in Singapore. And usually I fly out like once or twice every month. You can see Changi Airport is so empty. Maybe like there are only about 10 flights a day from Changi Airport compared to usually hundreds. So I miss going to Changi Airport. I haven't been there since February. So my talk today is on angle closure glaucoma, and you know it's an important form of glaucoma in our part of the world. It affects more than 20 million people. Now, there's a spectrum of disease for angle closure glaucoma, and what we see as glaucoma specialists are those with a very more advanced disease. And this is the prevalence is about 1 to 2% in different Asian populations. However, a lot of people have the very mild or early stages of the disease where they just have narrow angles, and this is called primary angle closure suspects. And about 5 to 8% of general population above the age of 40, at least among the Chinese people, have narrow angles. So it's a pretty common disorder. But as you can see from the difference in prevalence, only 1 to 2% have angle closure glaucoma, which means that most of the people with primary angle closure suspects will not progress to angle closure glaucoma. So in the old days, the data is very limited, and we thought that maybe 30% of suspects will progress to PAC, and then 30% will progress to angle closure glaucoma. So overall, maybe about 10 to 20% will progress from PACS to angle closure glaucoma over 5 to 10 years. And the definition, as I said earlier, when I say PACS, I mean just narrow angles with no other abnormality. When you have PAC, it means that there's some pressure problem. Maybe the pressure is high, but the disc is healthy, or the patient may have some synovial closure, but the disc is still healthy. And finally, angle closure PACG means you have disc damage and visual field loss. So this is the spectrum of disease. So let's share the common example. This is a 59-year-old lady. She is asymptomatic, and she has a hyperopia of +2 diopters. Her vision is 6/6 in both eyes. She has very mild cataract, and she has a bit of shallow anterior chamber. Her intraocular pressure is 13 and 14, which is normal. Her optic disc and visual fields are normal. But on gonioscopy, you can find angles are all closed, but no synechiae. And so she has what you call angle closure suspect of narrow angles. And here you can see the anterior segment OCT. You can see obvious apposition of the iris to the angle, showing you there is closure of the angles. Her lens is not particularly very big either. So this is the patient who is normal visual field, normal IOP, normal minimal cataract, 6/6 vision, and she has PACS. So in your clinic, you see such a patient, how will you manage this patient? So let me give you some options. One option is a laser PI in both eyes. Second option is a pilocarpine in both eyes. Third option is a bilateral phacoemulsification with IOL. And the last option is observation. Now remember, this patient is a good vision, 6/6, and has minimal cataract. So, okay, so these are the different options. Now, most people would probably go for either laser iridotomy in both eyes or observation. It's very unlikely that you would do a bilateral phaco because her vision is excellent and she's still asymptomatic. Now, of course, if you tell that patient, observation, let's observe you, what if the patient gets acute angle closure attack next month or maybe next week? And this is what we worry about because acute angle closure can be blinding. And another worry we have, of course, is if the patient comes back 1 year later with very bad chronic angle closure glaucoma and with optic nerve and visual field damage. So as ophthalmologists, we also worry about being sued because we told the patient observation and he comes back with acute angle closure or with chronic angle closure glaucoma. So this is what we worry about. And remember, there is a prophylactic treatment available for PACS, laser iridotomy, to treat the pupil block element present in angle closure glaucoma. So laser iridotomy can prevent progression, prevent acute attack, but also you must remember that there are some adverse outcomes of laser iridotomy. For example, patients may have visual symptoms, like they may complain of a line or some visual glare or visual disturbance. Of course, you have a risk of a corneal endothelial damage, and there's some reports of cataract progression as well, apart from things related to the laser procedure, such as IOP spike or bleeding. So there's also some mild side effects of laser iridotomy. So how should you decide? How do you counsel your patients who have bilateral PACS? How do you counsel them for the risk versus benefit of different treatments? What is the risk of progression versus observation? And who are the people who are at risk of progression compared to those who have no risk? So these are the different questions that we were trying to answer when we did a couple of studies over the last 5 to 10 years on to answer this question of how to manage people with PSCS without any cataract. Now, remember, there are 5 to 8% of Chinese people have PSCS, so we can't be recommending laser iridotomy for all these people because the economic burden will be very big. And especially for a country like China, there's a lot of people with PSCS. And so we wanted to do this study also in China to address the economic consideration of management of PSCS in the general population. And so we did this study called the Zhongshan Angle Closure Prevention Trial, or the ZAP trial. And it's a very catchy name, ZAP, for laser. And it's called Zhongshan because the hospital that was conducted this trial is the Zhongshan Ophthalmic Center, or ZOC, which is in Guangzhou in China. And this trial was published last year, called the ZAP trial, and it was published in the Lancet, and the results of the trial was published last year. Now, we also did a similar study in Singapore called the Analyst trial, which has not been published yet. And the reason is because in China, they are very fast in recruitment. We started about the same time, but in China, they recruited like almost 1,000 patients in less than 6 months. In Singapore, we took like 3 to 4 years to recruit like 500 patients. So imagine how fast things move in China. Okay, so they can mobilize a lot of people, and similarly, the recruitment is super fast for any kind of trial. So remember, in both studies, the reason for doing the study is to answer the question, how should we manage people who have asymptomatic narrow angles, or PSCS, and no cataract? So both studies were similar methodology. There was randomized controlled trials, recruited people with bilateral narrow angles above the age of 50, and they were randomized to 1 eye of iridotomy and 1 eye no treatment. So it's an intra-patient randomization, and followed up for 6 years in China for the ZAP trial, and for 5 years in Singapore for the Analyst trial. And the ZAP trial recruited almost 900 patients. So it's a very simple study, 1 eye laser, 1 eye no treatment. And they were followed up for 72 months. And the main outcome measure was the incidence of primary angle closure, or PAC. And this was defined as IOP above 24 on 2 occasions, or the development of PS in at least in 1 clock hour, or acute attack of angle closure, APAC. So these were the main outcome measures. So the outcome measure was not development of primary angle closure glaucoma, but just PAC. And the secondary outcome measures, we looked at visual acuity, intraocular pressure, changes in angle width, as well as any adverse events. So here are the results of the ZAP trial. And here you can see, that the mean age was 59 years. There were about 80% were female, and most of the lasers were placed superiorly. There was some placed nasally or temporally. So this was depending on crypts that were visible. And patients were followed up completely, and there was good follow-up. Now, here are the main results of the study. And here you can see that over a 6-year follow-up, you can see that 19 patients in the laser group compared to 36 patients in the control group reached the endpoint of primary angle closure. So the incidence was 4.19 per 1,000 eye years for the laser group versus almost 8 per 1,000 eye years. So it's a little bit complicated to look at per eye years, but if you look at raw numbers, you could say that 2% progressed in the laser group versus 4% progressed in the no treatment group. So this is how we look at in terms of numbers, 2% versus 4%. So almost double the risk if you didn't do anything. Now, in the ZAP trial, they found that the risk factors for progression were people with narrower angles at baseline, but that was the only risk factor. And other factors such as the baseline IOP as well as the darkroom provocative test was not associated with endpoint. Now, we were very surprised from the ZAP trial at the low risk of progression in PAC. We expected a lot more people to progress in the untreated arm, but yet we found a very low risk of progression in both arms. So, as I said earlier, if you didn't do anything, only 4% progressed over 6 years. And if you did the laser, it was halved. Now, of course, the hazards ratio was about 0.5, which means that you have half the risk of, reduce the risk of progression if you did the laser. Fortunately, the laser was safe and we had no long-term adverse events. In terms of endpoint, all the endpoints was PAC, and we had very few people who developed PACG or glaucoma, which is a good sign. But on the other hand, it also shows you that if the progression was low, and the progression endpoint was only PAC, which means that the patient has got most of them have no visual consequence, as they have no damage to the visual field or optic disc. So what it shows us is that overall, the risk of progression from PACS in this Chinese population was very low, with or without iridotomy. And of course, we had acute ankle closure occurred in like 2 cases in the untreated group. So it's a very rare occurrence, 2 out of 800, almost 900 people. But of course, there's a risk, especially if you do pupil dilation, it can get acute ankle closure. But in terms of population-wide or epidemiological studies-wise, there is no recommendation for doing a large community program of screening and then lasering with iridotomy. So it is not warranted, at least from population-wide. So this is our main finding for China. Now remember, these are Chinese people who are considered slightly higher risk because the prevalence of ankle closure is higher in Chinese people. And certainly if you have a Caucasian population, is much lower risk. For Indonesia, I'm not sure because I do not know what is the data, but at least from the Malay eye study in Singapore, Malay people have quite a low risk of ankle closure as well. So if you say that the Malay population is similar to Indonesian people, then I would say also the risk is probably lower in Malay people. Of course, we also had a slightly younger population. These are people with a mean age of 59. And these are people because we recruited people who had asymptomatic narrow angles. And this is the population we wanted to target because they had no cataract. Of course, if you have a cataract, the solution, of course, is to take out the cataract. And so we are not looking at people with narrow angles with cataract. People with narrow angles with cataract, you would do cataract surgery. We were looking at people who had asymptomatic or no cataract or minimal cataract. And this is what this study population was about. The other issue of the ZAP trial was that the recruitment came from the community, and basically Professor Ming Wang He, what he did was he identified a community, one area of Guangzhou, and they invited everybody who was above the age of 50 to come for screening for eye diseases. And that's how they recruited so many patients in so quickly. And so it is a little bit, maybe if you do a community-based recruitment, these are people who are slightly less likely to have eye diseases compared to hospital-based. Now let's move on to the Singapore study, the sister study. And the Singapore study was called the Analyst study, and this is a paper that's about to be submitted very soon for publication. And Analyst stands for Asymptomatic Narrow Angles Laser Iridotomy Trial, okay, and this Analyst. Now, a lot of my colleagues disturb me because they say it's the anal study, because it sounds like if you put the hyphen, it's actually the anal study. So as I said earlier, it's the same study design, bilateral narrow angles above the age of 50, laser in one eye and no treatment in the other eye. But here we did only a 5-year follow-up instead of 6 years. And our calculation of power was much lower. We only needed 480 patients. So this was our calculation. And the Singapore study found a slightly higher rate of progression compared to ZAP. So we had a 9.5% progression in the untreated arm versus 5% in the laser arm. So again, the risk was about half, okay, if you do the laser. But we had a slightly higher progression rate. As I said earlier, in the ZAP trial was 4% versus 2%. Here we found 9.5% versus 5%. And the majority of those who progressed again was similar to ZAP. It was to PAC only. We only had 3 acute episodes, and this was 2 of them was in the untreated arm, and 1 was a bilateral acute episode. In terms of risk factors, we had slightly more risk factors for progression, as in ZAP. Those with narrower angles at baseline. We also had people with higher baseline IOP, higher post-dilation IOP, as well as people with diabetes were found to be risk factors. So diabetics had higher risk of progression compared to non-diabetics in our analyst trial. So, as I said earlier, the summary-wise, 9% versus 5% from Singapore, and 4% versus 2% from ZAP. And why the difference? Well, we don't know why the difference. They're both majority are Chinese people, but perhaps in Singapore, they were all recruited from SNEC, so there was a hospital-based recruitment. In terms of angle width, we also found that the mean angle width was slightly wider in the ZAP trial. Of course, they were not the same people doing gonioscopy, so it's difficult to be a direct head-to-head comparison. And there could be some racial differences because Singapore is more of a multi-ethnic population, and there could be some differences in the Chinese people as well in Guangzhou versus Singapore. So these are potential reasons for why there's some differences. So overall, has these trials affected management of PACS? So in terms of, for me, I would say that these trials show you a very low risk of progression overall for PACS. And as I said earlier, the endpoint was PAC and not PACG. So very few people develop PACG. And it really brings me to think about whether we are over-treating PACS when we offer LPI for everybody with PACS. And certainly on the population level, we do not advocate PACS to be treated with LPI for everybody. However, as ophthalmologists at the clinic level, it is different. So when I see now a patient with like this asymptomatic narrow angles with PACS bilaterally, I will discuss with the patient the options of the laser iridotomy versus observation. I now quote the data from both ZAP and analysts and say that untreated, the progression rates vary from 4 to up to 10%. And by treatment, you reduce the risk by half. And I'll give them the data of the risk of the surgery as well as the risk of the progression is only to PAC, and really let the patient make a decision as to the treatment that they want. And many patients will tell me, I understand now the risks are involved as well as the risk of no treatment versus laser. And some patients will say, I'm happy to observe and see what happens. Other patients would say, okay, I would rather do the laser to reduce my risk. And so, this is an informed decision that you make with the patient. Sometimes the patient will are not sure, and they will say, I don't know, can you decide for me, or, they are in doubt. And also, I will also look at the patient, whether they are likely to be follow up or not. I mean, this is very difficult to judge, of course, but some patients will tell you, oh, I'm unlikely, I live, in a different country, or maybe for Indonesia, I live in a province. I may not be able to come back for follow-up. And then perhaps, you should then do the iridotomy to be sure, because there's always a risk of no treatment. Of course, as I said earlier, if the patient is cataract, I would offer cataract surgery instead, rather than doing anything, just do cataract surgery. Now, remember, this is something which is an informed decision that you make with the patient. And there's always a risk of letting the patient go and the patient develops acute attack as well as chronic ankylosing glaucoma. So these are the risks that you have to decide with the patient. And as I said earlier, for those older people with cataract, just take out the cataract with a phaco, and there's no need for LPI. Now, who should go for LPI among those that you see with PACS? Okay, if they have one eye has PAC or PACG or acute attack, and you are, of course, the other eye is PACS, please do the iridotomy for both eyes. So this is clear. But for if you have bilateral PACS, these are people who I would consider for laser iridotomy. Firstly, if they tell you they have some symptoms, okay, sometimes they tell you they may have some headache or some intermittent eye pain, and you're not sure, of course, go on the side of caution and do the iridotomy, offer them the iridotomy. The second group are people who need regular pupil dilation. For example, diabetics, people with macular problems or retinal problems. Please do the iridotomy because of the risk of dilation and getting an acute attack. And as I said earlier, in the Singapore trial, diabetics had higher risk of progression as well. And I said, and the third reason, of course, is for people who have poor access or have poor follow-up, and maybe they live in the province or and they may not be able to come for follow-up. It's a good reason to do iridotomy as well. Family history is controversial. For me, if they have a strong family history of ankle closure glaucoma, I would also do the laser iridotomy. But there's no good evidence for this. And finally, of course, as I said, it could be patient-specific. Look at the angles properly. If there's a lot of pigment in the angles, this could be another warning sign. The patient, for example, may have blotchy pigment in the angle, which could suggest a possible intermittent spike as well. So this is also patient-specific. And as I said, population-specific. Some populations will have higher risk than others. And certainly, I cannot say for Indonesia, but in some populations with a high prevalence of ankle closure, for example, in the Burmese people, Myanmar population, there's a very high prevalence of ankle closure. I would certainly be more likely to do an iridotomy. In fact, Myanmar has one of the highest rates of ankle closure described in population-based studies. So again, this is something that depends on the population. So in summary, I've described to you today the current thinking about the management of asymptomatic narrow angles or PACS without cataract. The ZAP trial and the Singapore trial shows you there's a low risk of progression and then an option of observation without any treatment. You have to discuss the risk with the patient, and overall, I would say to the patient, no treatment carries a risk of between 4 to 10%, and doing the laser will reduce the risk by half. If you're in doubt, or the patient is in doubt, I would say just do the laser iridotomy. And of course, patients with cataract, just remove the cataract and do a phacoemulsification. That is the solution. So I'd like to acknowledge here all my different fellows who've been working on this trial. We've been doing this trial for almost 8 years, and it took a very long time to recruit these patients and then follow up for 5 years. Of course, Ming Gong Hee, David Friedman, and Paul Foster, who we came up together with this same protocol for the two sites. Our collaborators in Singapore and NUH and Tan Tock Seng, as well as my colleagues from the Singapore National Eye Center. Thank you for your attention.
Thank you. Thank you, Prof. Tin. There was a very interesting lecture. I think, I believe there are so many questions from the audience. Please do type your question on your Q&A box, and then we will address them later on. And then another speaker will be Dr. Vivin. Dr. Vivin is a glaucoma subspecialist from Department of Ophthalmology, University Diponegoro. She has done her PhD from University of Gadjah Mada, and currently he is the head of the JAC Candi Eye Clinic. So time is yours, Dr. Vivin, please.
Yeah, thank you, Professor Ike, as a moderator. Do you can hear my? Oh yeah.
Yeah.
I try to start my share screen. Ya. Kok bisa? Nggak bisa? Oh, ya. Assalamualaikum. Good morning, Prof. Auntin, especially, and also all of the attendants. This morning, I will present a case report about acute primary angle closure or IPAC and primary angle closure suspect or PACS. On February 26, a woman, 58-year-old, come to the clinic with this complaint, feel uncomfortable on the right eye. And this is the history of illness 6 months before she suffered from pain, red and blue vision of the right eye, and she got anti-glaucoma from other ophthalmologists, and the complaint was improved. But 1 week before she come to the clinic, she experienced the same complaints. This is the status of ophthalmology of the patient. The right eye visual acuity was 20/25. Hyperemia of the conjunctiva. Cornea is clear, but under chamber is yellow with conioscopy narrow and pace in 1 clock hour. Pupil diameter is 3 millimeter and lens intumescence. In fundoscopy, I found optic nerve head CDR 0.4 and the IP still 24 millimeter mercury. And for left eye, visual acuity is 20/20. Everything is within normal limit, but I found shallow anterior chamber with conioscopy and narrow angle. And fundoscopy, CDR still 0.3 and the IOP quite good, 13.7 millimeter mercury. So I diagnosed this patient with right eye PAC or primary angle closure with amateur cataract, and left eye PACS or primary angle closure suspect. And I agree with the previous ophthalmologist to give her timolol maleate 0.5% BSDT for right eye. And I did a laser peripheral anatomy for both eye. But for this letter, she come again to the clinic with chief complaints, very severe pain, red and blue vision of right eye since 1 day before. And this is the clinical condition that I found when she come 5 days after LPI. The right eye's visual acuity was hand movement, mixed injection, corneal edema, very shallow anterior chamber with dilated pupil and lens intumescence, and the IOP going increase 46.3 millimeter mercury. And the left eye still good, 20/20 with the normal limit, and the IOP 11.3 millimeter mercury. I make a different diagnosis for this patient. Right eye is ABAC or acute primary angle closure and phacomorphic glaucoma. And I make a working diagnosis. Right eye ABAC with amateur cataract and left eye PACS. So I plan to manage the patient with give her topical and oral anti-glaucoma and topical steroid also, and plan to do lens extraction with IOL implantation for right eye. Before I continue my presentation, this is all maybe. Yeah. Which anti-glaucoma that should not given to patient with acute primary angle closure. Maybe we will wait for a minute. Yeah. Yes. The result more than 50% choose prostaglandin analog. Yes, I agree with that because prostaglandin analog is a pro-inflammatory substrate, so it will increase or make the inflammation more severe in eye with ABAC. Okay, I will continue my slide. This is the biometry of the patient. Axial length is 22.78 millimeter and ICD only 2.12 millimeter for the right eye and 22.91 millimeter and 2.26 for left eye. And this is the condition perioperative. I'm sorry, I don't have the video of the operation, but this is the follow-up after 5 days of post-surgery. We can see here the inflammation is rather severe, but the fibrin and also the sweat spot in the cornea. But visual acuity is still 20/80, conjunctival hyperemia, corneal edema, and pupil dilated. But IOP is going down 11.2 millimeter mercury. I still give the patient steroid topical. This is the last condition of the patient 4 months after surgery. This the right eye visual acuity is 20/20 emmetrope, the pupil still mid dilated, pseudophakia and IOP good, 11 millimeter mercury. By the way, the left eye, I already do the LPI, but we can see here that under chamber is still very shallow. Very shallow. It is in front of the pupil, still like that, and also Van Herik is that one. Two questions that emerged in my mind is what condition that trigger glaucoma attack in 4 days after laser peripheral odotomy, and what should we do to the left eye? I think this is what I can present. Thank you for the attention, and I need a suggestion or opinion from Prof. Auntin. Thank you.
Yeah, thank you, Dr. Vivin, for things that case is quite common in Indonesia. We just proceed the speaker to Dr. Arum. Dr. Arum is graduated from, I think, yeah, the profile, okay. Yeah, Dr. Arum is graduated from University of Erlangga, and she has been done a glaucoma fellowship in JSA. Please, Dr. Arum, time is here now.
Thank you, Prof. Ika, for the opportunity. Let me share screen my slide. Okay. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, Prof. Auntin and all the panelists and attendants. This time, I would like to share my case report about CACG with mature cataract. I have no financial disclosure with presented material in this presentation. The case report, female, 62 years old, came with blurred vision and pain on left eye since a month. And from history, there was diabetes mellitus and a family history of glaucoma. From physical examination, we found the visual acuity of the left eye was hand movement with the IOP 47.9 and corneal edema, shallow anterior chamber, irregular iris, mid-dilated and irregular pupil, and cataract. While on the right eye, we found shallow anterior chamber with grade 3 cataract. We gave initial therapy oral acetazolamide loading dose, and the IOP became 22.9. And this is the maintenance therapy. And we plan to do trabeculectomy. On 1 week monitoring, the IOP of the left eye was 21.3. And there was improvement. We found the cornea clear with KP, and we underwent corneoscopy, and we found on right eye grade 1 modified Schaefer on 3 quadrants and grade 2 on 1 quadrant without PES, and on the left eye close in all quadrants with PES. Okay, regarding this case, which one do you prefer? One-step phaco trap or sequential surgery trap followed with phaco? Okay. The result of the vote, 50% choose one step and 50% choose sequential surgery. We continue the maintenance therapy, and we plan to perform one-step phaco trap. And this is the biometry we found from biometry. Both anterior depth was shallow. And we do the phaco trap, and on 1 day post-op, the visual acuity of the left eye, hand movement with the IOP 11.9, with diffuse bleb, corneal edema, anterior chamber, and mid-dilated and irregular pupil. And we continue the post-operative therapy. And on 1 week post-op, the visual acuity, still hand movement, and the IOP slight increase into 17.2 with flat bleb, and the corneal was clear and deep interchamber. And from posterior segment, we found the optic nerve CD ratio was 0.9, and we add acetylcholine tablets, and we underwent a removal of reducible suture and do bleb massage, and the IOP became 9.5. On 3 weeks post-op, the visual acuity was improved into 0.2 with pinhole 0.4, but the IOP is slight increase on 0.9 with flat bleb and deep anterior chamber. So we do the bleb massage again, and the IOP lowered down to 14. At 5 months post-op, the left eye visual acuity is 0.4 with correction, and the IOP is maintained on low teens with 1 drop glaucoma medication. And we also do cataract surgery for the right eye 2 months after the left eye surgery. And this is the OCT of the left eye on 5 months post-op. We found that there was thinning on or NFL thickness of the left eye. And for the perimetry, we used 10 degree for the left eye, and we found a tunnel vision. From many previous studies about coding this case, showed that there were no significant difference in mean IOP and BCVA between 1 or 2 step surgery. Either 1 or 2 steps surgery had comparable success rate and reduced number of glaucoma medication. And from previous study, Phacotrap had some advantages, which is it can widen the interchamber angle and short time to improve BCVA. Sorry. While in the sequential surgery, the advantages was better long-term IOP control and shorter duration of surgery. And 1 step or 2 step surgery in CSCG with major cataract, according to many previous studies, have similar in safety and efficacy. Which procedure we choose is depend on socio-medical factors such as preoperative IOP, comorbid, visual rehabilitation, and patient economical background. Thank you.
Yeah, thank you, Dr. Arum. That's a great presentation. I think it's time limited, especially for Prof. Auntin. There is a question from Q&A addressed to Prof. Auntin. From your letter, based on the ZEP trial and analysis study, it is suggested that widespread prophylaxis PSCS patient is not recommended. Yeah, right. Right, yeah, Prof.
On the population level.
Yeah. But however, you mentioned that that study is based on the community study. Yeah. How about in regard with the patient who need more often to dilate the pupil for regular checkup, in the retina, for example, for diabetes patient, And then the case that Dr. Vivin has been presented, even though we already did the PEI and the acute attack still happened. So there is another question actually, Prof.
Okay, well, let me answer that first of all. The first one I mentioned earlier, if you need a regular dilation, they should undergo iridotomy in both eyes, as I said earlier. And so, firstly, so I'd like to clarify that. And the second question about the patient with the acute attack after the iridotomy, there's a couple of reasons could explain this. One is that it could be a patient who have a lens subluxation. I'm not sure whether the lens was subluxed. And secondly, the other possibility is that it's a plateau iris. Plateau iris is not may not be relieved by pupil block by iridotomy, which only relieves the pupil block. Yeah, and of course the other possibility is whether the iridotomy closed off as well. So these are all possibilities for that patient.
Yeah. So there is also another question regarding to your lecture things. When we already decide that we don't have to do the laser PI, what the period time of the patient need to follow up? I mean, I think it's very important patient to follow up. And then is it enough 1 year or more? And then there's another necessary ancillary test probably. Does it need such as anterior segment OCT to examine the abnormality of the angles? Or for example, how is the TISA, trabecular iris space area, or AOD and lens fault count? I think it's very important to see whether what kind of mechanism of that patients. What do you think?
Yeah, also usually I do anterior segment OCT to document the angle closure and also look at the lens vault. But these are people who, as I said, who are asymptomatic and usually they have good vision. So on most of them, the lens vault will not be normal. Yeah. Of course, as I said earlier, if they have cataract, it's a different story. You should just remove the cataract. In terms of follow-up, usually I will see them once a year. These are for people observation. Yeah. Going back to the other patient who had the acute attack in one eye, PS in one eye, and the other eye was PACS. She should do the iridotomy in both eyes because PAC is one absolute indication for doing the iridotomy. Yeah, so it's correct that because the patient had a PAS and high pressures as well, she should have done the iridotomy. It's correct. Unfortunately, the patient got an acute attack.
Yeah. Do you think that using the gonioscopy only or and also the biometry can be decided whether the patient can do the PI or not?
No, yes, gonioscopy is very helpful because firstly, it will document the angle closure in terms of the positional closure. Gonioscopy will also tell you whether there's PAS, and sometimes you can look at the pigmentation, how much pigment blotches there are in the angle. So of course, it is absolute that you have to do gonioscopy on your patients. The anterior segment imaging is just for documentation. And also you can follow up looking at the lens and the lens fault as well. So it's more for documentation. But if you don't have anterior segment imaging, gonioscopy alone is sufficient to make the diagnosis of PACS and PAC or PACG. Yes.
Yeah. This is another question from Q&A. Is it possible that we can do both? I mean, LPI, then followed by I think in the same times, yeah, LPI in conjunction with gonioplasty. What do you think about that, Prof?
Okay, so firstly, it depends on what disease we're talking about. If you're talking about PACS, then the LPI is the first step. And sometimes after the LPI, there's persistent apposition, right? And so the question is whether you should do an iridoplasty for persistent apposition. And this is something which we don't know the answer. Personally, I don't do because I'm scared of doing iridoplasty because it may cause corneal endothelial damage, especially with PACS people. They have no other problems, right? So you may creating a problem unnecessarily. Also, sometimes if you do a iridoplasty badly, you may create some PS from the iridoplasty itself. So I usually don't do iridoplasty for PACS post-apposition. If you have an angle closure glaucoma, it's different. After iridotomy and there is a persistent apposition and the pressure has been high still, I think, if you think that the apposition can be relieved with iridoplasty, I think there's an option, because it is a patient with angle closure glaucoma. So they have glaucoma damage and they have visual field damage with high pressure. And so in some cases, I would do the iridoplasty, particularly if it's a plateau iris configuration. Yeah. But again, iridoplasty has some risk. And if you're not familiar with iridoplasty, better not do it, because you may damage the cornea, because these people have very shallow anterior chamber. And if you do the iridoplasty badly, you may be burning the cornea endothelium. I've seen patients with very badly burnt cornea endothelium from the iridoplasty. So I think better be careful if you're not very familiar with where you're doing the iridoplasty. Yeah.
Okay.
But this is for people with PACG, with persistent apposition and high pressures, and usually with plateau iris. Yes, this could be iridoplasty. But whether you should do a simultaneous iridotomy followed by iridoplasty, there's one study from China which did a trial of this. They did a trial of PAC and PACG, iridoplasty versus iridoplasty plus PI versus PI plus iridoplasty. And so they found that there was slightly a better outcome in the iridoplasty arm, but it's difficult because you're not sure what they're doing, what mechanism they're doing. So usually it doesn't make sense. Then it makes sense to do the iridotomy first, and you see, is there persistent apposition? If there is, then you do the iridoplasty. That's the logical way, rather than doing it straight off, because you don't know what is the effect of the iridotomy. So I think I would do one by one.
Yeah, it depends on the mechanism of the patient itself. Yeah, PASC, I think this is very difficult to decide which treatment that we have to manage. But based on the case one, Dr. Vivin has been presented. How about clear lens extractions? For the fellow eye of the acute attack.
Yeah, I think that is an option, because that patient's very shallow and she already had the bad acute attack in the other eye. So again, you have to discuss with the patient that option of doing it. Yeah, I think it's an option, because you're worried of getting the acute attack. It's a very, very shallow anterior chamber, and so it could be a very big lens component, and it certainly is something you should discuss with the patient. Yeah, but of course, you must be pretty good in doing phaco. It's such a shallow anterior chamber. Yeah, and if you're not so confident, then better refer to your cataract colleagues. Yeah, if not, it could be go horribly wrong with a good vision. Yeah.
Yeah, so thank you so much. I think there is a lot of question actually, but
no problem. I can answer.
Okay, one more question. Can I? Yeah, I'm just curious because I just read the journal about the ZEP trial, and then the result from multivariate analysis, which is show that lens thickness is very important factors for PSCS. It has a high risk factors, but it has not significantly difference between the two groups. The eye with LPI and then the one without LPI. However, when we see from other table, there is another variable is like limbal anterior chamber depth and also angle depth. I think is significantly different, but it has a low risk when we see from the multivariate. I think is do you think that it seems to me that LPI has an effect, an effect in that study, and then that can deepen the angle, the angles, and then deepen the anterior chambers. So what do you suggest? What your opinions? So still we just observe the patients, or we do what the high risk of the patient. I think the risk of the patient, we have to see the mechanism of the patient itself.
Yeah, so remember what I said earlier is that you have to discuss with the patient. These are people with narrow angles without any other abnormality. And so, this is a very small group of patients who have no cataract and good vision. And so there's an option of observation, but in doubt of the patient, if you're worried that the patient, then do the iridotomy, because, as I said, there's also a risk of progression. But what the ZEP trial showed was the risk of progression is pretty low, okay? But of course, in that individual patient, that patient may be worried. What if I'm the unlucky one who may get the progression or get the acute attack? So, I think, you have to discuss with the patient, and that patient will have to decide for himself about the option of the treatment or no treatment. Yeah. So I'm not saying that there's no treatment is required for everybody with narrow angles. I'm not saying that. I'm saying that you discuss with the options, and we have good data now on observation versus no treatment.
Yeah.
I'd like to make a comment about the second case just now, and the option was whether a phaco trap or a trap.
Yeah.
And the third option, of course, is just a phaco alone. I mean, that was the third option, and because probably it's such a very bad mature cataract, phaco alone is also an option because you don't know about the disc finding, and you could just do a phaco alone and then take a look after that. And if the patient then subsequently requires a trabeculectomy, it could be a second stage procedure. So it's also an option, because that one, the cataract was so mature and you can't see the disc. And of course, they had acute attack.
And maybe the phaco with the gonociliasis, I think is one of the option, right?
Yeah, it could be as well. Yeah. I mean, if there's lots of PS, So that could be an option. I don't normally do a trap alone in such cases because it's obvious that the lens is the main contributing factor in that patient. So the option has to be the taking up the lens. And then the trap alone is probably not an option. It's either a phaco alone or a phaco trabeculectomy, I would think, in that second case.
Yeah, I think.
May I, Prof?
Yes.
May I? Yeah. Thank you, Prof. Angtin. As we know that family history is one of risk factor for glaucoma. According to SAP analysis result survey, if we found a patient with glaucoma, who should educate to do LPI? For example, my patient, she's a mother. Do we have to educate maybe her son or her daughter to do LPI? Because I have,
Yeah, very good question. So if you have a patient with PACG, ankle closure glaucoma, the studies have shown that the most high risk are the siblings. The siblings are at risk. So you ask them to bring all their brothers and sisters to take a look first. And if they have narrow angles, then you could discuss with them the option of doing the iridotomy. So that is the siblings is a good risk. Children is very unlikely. I mean, it depends on what age of the children. Yeah, but I think children definitely should be warned of as well that when they get older, they may also need to observe for the ankle closure and ankle closure glaucoma. But I would definitely advise the siblings, the brothers and sisters, to come first. Yes.
Yeah. Thank you, Prof.
Thank you,
And
Prof.
then,
sorry, because I was doing a clinic today, and then
I know that you have to go back to your clinic.
Sorry.
I think your time is up.
I normally don't work on Saturday, but this is the once month I do a clinic.
Yeah. Okay, time is up because Prof. Angtin should go back to the clinic. So hopefully the lecture and this case-based approach will help improve our daily clinical practice in managing primary angle closure disease patients. I would like to say thank you to all the participants who has joined us this morning in JSA Second Glaucoma Saturday webinar. Thank you for JSA team for making this webinar possible. I would like also say thank you, and then send my biggest appreciation to our international speaker, Dr. Aik Ahmad from Canada, and Prof. Angtin, thank you, from Singapore, who despite their busy schedule have joined us today in this webinar. Okay, thank you, Prof, for your time. And then time is come to Dr. Rini, close this webinar.
Okay, thank you, Prof. Ike. I guess we already reached the end of our session. Maybe we can have our last polling. Okay, thank you so much. So I would also like to thank our foreign speaker, Dr. Aik Ahmed, and also Prof. Tin Ong. and also our JC speakers, and also 1.4K participants that already joined our webinar today. So it's been such a fruitful presentations and also discussion. Hope it will help us to improve our knowledge and do our daily practice. So last but not least, this is our next week's webinar, Managing Eyelid Problems for General Ophthalmologists from Oculo Service. So we invite you all to come and join our next webinar. I'm Rini, your host today from Glaucoma Service. See you again and thank you. Stay safe all. Good afternoon.
Thank you.